There's going to be a lot of things that are eye-opening as far as the processes go. And like I said, I just want you to have an open mind. The goal here is feedback. We want your input. You are the folks who are implementing all of this poolside. We know there's a disconnect between the lab scientists, the people in admin positions that put these rules into place, and the folks in the field. And what we want is greater cohesion, so we can work together and actually get real results, real answers, so that way we can better the industry going forward. That's the goal. At some point during this, we are going to show you some of the change requests that we have submitted, this group has submitted. And we are also going to explain what you can do about it. Make your own decisions, of course, but we're gonna at least point you to where you can vote if you choose to vote. We hope that you do. The way that we get things done, obviously, is when we're involved. If there's tens of thousands of us out in the field, and trust me, we're all hands on it, and we know this stuff better than a lot of people. And if we're not involved in these decisions, then these decisions aren't going to be near as good as they possibly could be. So I know everybody here knows me, and you also know that I like to buck the system, buck the status quo when it comes to some of the different chemical things going on. All right, mute yourself. But as far as some of the different chemical things we have in the industry, and I don't put my name on anything, but you guys can see on this screen, my name is on this one. So that should let you know what I think about it. I've worked with these folks. I've spoken with the folks that we're about to, that you're about to hear from. And I believe in the change requests that they've put together, and I believe this is what should be part of the code. And we're going to go through and we're going to show you the information, good, bad, or indifferent. It's going to be all the facts, and you make your own decisions. But I think you'll see why I added my name to this one as we go through it. So with that, Jen, do you want to take us to the next slide? So here's who we have with us today. Of course, I'm Rudy with Aquatic Facility Training and Consultants. I also have the Talking Pools group, which is where we're going live right now. And I have a column with Kuechler magazine. That's me. Most of you know me from either my CPO classes or from somewhere along the past 30 years of me swinging a telepole, one or the other. With us, well, we'll just let everybody introduce themselves. We have the pool guy extraordinaire, Mr. Roy Vore. Roy, if you could say hello.
Hi, this is me. A lot of you know me. It's I started with Bacquicil in '91, was there 14 years, a year with Arch, 8 years at DuPont, 7 years at Biolab, and in June when the market got tight, I was one of the guys that got cut loose. So now I've got a Ford Transit Connect with a pool pole on the top of it and running my own pool service. And I probably am the only person in the industry that has done all the kind of bacteriology we're going to talk about and run a swimming pool for 25, 30 years. So it's like right now, if you're a pool boy, I'm in the same category as you.
Next, we have Dr. Tom Kuechler. Tom, okay. Say hello.
Hi there. I have a PhD in inorganic chemistry. I've been in the water treatment field for about 30 years. This is all industrial work, research, technical service, regulatory support, commercialization with a buy-side manufacturer, either first of all Monsanto and then Occidental Chemical. I've done a lot of field trials with chlorine and bromine biocides. Retired a couple of years ago, and I've been working on the CMAC Chlorine Stabilizer Ad Hoc Committee, which you're going to hear a lot about today. And I'm a consultant, independent consultant for a consortium of chlorinated isocyanurate manufacturers. Jen?
Hi, I'm Jenn Huang. Most of you don't know me, but I'm looking forward to getting to know all of you. So I am a chemist. I'm a technical and regulatory consultant. I have over 15 years of experience in various settings, biotechnology, academia, biopharmaceuticals, manufacturing, and research. And about 5 years of that has been in the water treatment industry. I've had either current or past involvement with a lot of different professional organizations. Some of them will stand out to you, will be the PHTA's Recreational Water Quality Committee. I'm not on that committee, but I've been readily active in following them for a couple years now. And also I've had involvement with the CMAC Chlorine Stabilizer Ad Hoc Committee, which you will hear us talk a lot about today. And I just want to give a disclaimer. I also worked at Oxy, and like I said, I'm a scientist first and foremost, and I'm an independent consultant second, and that's always. But I do consulting work for the Isocyanurate Industry Ad Hoc Committee, which is a consortium of isocyanurate manufacturers. All right, ready to take it away.
So here are our goals, and I guess I touched base on them a little bit if you came in right around that 3 o'clock mark. But right now, I can't express enough the value of intel from the field. That's the biggest missing component. At least it's one of the largest missing components, is that lack of cohesion, again, between what happens at this CDC with the Model Aquatic Health Code and us in the field. And that's why a lot of times things don't make sense because, you know, well, nobody's really asked us before. So that's the goal here. So we want to put that together. We do need to voice our opinions. You know what works, you know what doesn't work. We need to hear that. We were speaking last night, I think, and you guys, you know, chime up in the chat box if you want to, but a lot of the things we deal with as far as worrying about cyanuric acid levels is in relationship to the CDC's fecal incident response guidelines. And one of the things we spoke about was, you know, diarrheal incidents and the frequency of occurrence. And I don't know how many of you guys have had to respond to one of these and treat one of these, but I'm going to guess it hasn't been that frequently. So it's not something that happens weekly, monthly, or even annually for a lot of us. In fact, in my 30 years, I don't think I've actually had to respond to a diarrhea incident. So this is the kind of information we need to know, because it's, and even beyond that. So we're going to talk about some outbreak data that we got for you guys. We do actually have some information from tests from the field, and then of course real world scenarios, and we're going to talk about the CDC, the CMAC, what all this stuff is and what it means and why we should care as well. But then again, we want the feedback, Jen. So next slide. All right, so some different codes that are out there as well. The PHTA, we know who they are, right? The Pool and Hot Tub Association. For those of you that are certified, that's the new letters that NSPF used to be, or NSPF and APSP. They've kind of merged. And the ANSI standards, and APSP had a long history of standards. This is also out there. Some other things that we have going on as well. And like I said, the CDC's MAHC, it's driven by the committee for or the Council for the Model Aquatic Health Code, which is a group of individuals who get together and research these things to offer the changes. And some of the ones we're going to speak about today. Okay.
I just want to add one difference that Rudy touched on is that PHCA Standard 11 is ANSI accredited, and the CDC owns the MAC, which is driven by the expertise of the Council for the Model Aquatic Health Code.
All right, so the Model Aquatic Health Code. This is a nonprofit organization. I know you guys can read through this stuff. So it's owned by the CDC. They put this together. It's basically, it's a health department code. It's a huge health department code. It's meant to be looked at as a resource. There are states that don't have pool codes, and there are facilities in those states who want some type of guideline. And you'll quite often see them refer to this to use at their facilities. You may also have, Craig, I'm sorry to hear about that. 5 to 10 a season. Ugh. Anyway, so Craig has lots of diarrhea accidents in his pools, but in either case, so a lot of times when a state goes to make changes to a code, instead of having to reinvent the wheel, they turn to this Model Aquatic Health Code where the science-based information is already contained, and they can pull and pick items from that. They don't always adopt the entire thing, but it is a valuable resource to those facilities. The CMAC members, they develop and discuss the different changes that come about. They coordinate, they process, they spend hours on this. I don't know what's happening in Georgia, Ronnie, Craig, but you all keep that stuff there. So intent and purpose, the goal is to, again, be a resource to help in public pool regulations. As far as the vote goes, we're going to talk more on that as we go along, but we do have an opportunity. I'm just reading, there's a whole slew of, for those of you that can't see the chat box, there's a whole slew of diarrhea comments going on in there. So we have one every 2 years in Florida. So in either case, this is valuable information. So anyway, back to this here, just a bunch of comments. The main thing here, again, after we go through this, I want you guys to keep an open mind, and we want your input. Next slide.
I just want to add one thing to emphasize. We talked about this last time, but we're talking about the CMAC and the vote on these various change requests and proposals that are being made to change the code. But there's a couple things to say about that. We mentioned this last time, but it's important to understand the demographic for this group. Like you said, it's run by some health people, and therefore 50% of the vote is weighted by public health officials, and then the rest is industry and everyone else. So just want to point that out, and potentially that should be modified to do a breakdown of different groups, and maybe you guys should be one of those groups. Instead of it being 50-50 and just dividing it up as public health officials and then everyone else. And if that seems to make sense, we'd have to make good cases for that, but that's something to consider. But that's the way it's being driven now. So, and most of those public health people are very, very narrow-minded, I'll just say that, with regards to, being against cyanuric acid and not, and a lot of them don't understand a lot of this chemistry, to be honest with you. Also, they changed it as of the last go around because there were some controversial proposals that were made. They decided that a passing vote needed to be 61% overall or higher in order for any change request to be considered a favored yes. So I just want to point that out. Roy, your turn.
Well, let me give you a little background on where the Model Aquatic Health Code came from. CDC started recruiting people for it back about 2006, 2007. A lot of us started working on it about 2009. We got the first edition out in August 2014. A lot of the microbiology in that first edition, I was on the Disinfection Water Quality Committee. So some of the backgrounds that you'll see in there, I was on that, and all that stuff that was on secondary. All the stuff that was on secondary disinfection came out of that.
Whoever that is.
I think that's Brooke. Brooke, can you mute?
Yeah, hang on, sorry.
I got you.
Okay, so currently we're on our third edition cycle. In here, it came out in 2018. We're in the review process now, trying to come out with a new edition in 2021. You know, it's a model code, and it's like Rudy said, some states like Alabama don't have a state code. So it's something that they can just cut and paste out of it and put it in there. And if you've ever looked at the annex in there, it's about 300 pages of about everything you ever wanted to read, plus all the references on that. But the waterborne outbreaks, these are the ones that are reported of crypto that are documented by the CDC there on the bottom line. So they're not that many outbreaks of crypto, but when they are, they're typically in hundreds, if not thousands of people that get sick with Cryptosporidium. So crypto gets all the big press. Next slide, Jen. Okay, if you know my sense of humor, you know why that big circle is brown, because those are the diarrheal incidents, and these are the number of cases. So 89% of all the people that report getting sick have diarrhea on there. And it's about 88% crypto, and then there's another 1% crypto and Giardia mixed in there. All those other organisms up there on the top, you know, the E. coli, the Shigella, the norovirus, the Giardia, the Legionella and spas, they're considered chlorine sensitive. And that little wedge up there, there has never been a documented case of E. coli, Shigella, Giardia, norovirus when there was 1 ppm of chlorine in the water. And that goes back with our CDC records to 1978. The records aren't perfect, but the evidence does not show a single outbreak when we had 1 ppm of chlorine in the water as measured by a DPD kit. Next slide, Jen. All right, what do we know about germs? You know, where did we get all the information? Well, there was a bunch of work done in the 20s and 30s, but it was different methodologies, and it's really hard to get back in there. So we started to really investigate pools in the mid 1950s and early 1960s. And then in the early 1960s, we developed standards for swimming pools that came out of drinking water. And they used the same indicator organisms, and that's E. coli and fecal streptococci. So they tell you that something else might be in there. And then in 1963, 64, the USDA, before EPA existed, came up with the infamous 30-second rate of kill. But when they did that, they said, this is laboratory data, and what we really need to do is take it out to the field and measure it. Well, they did that in the mid 1960s, but unfortunately, when they did that, almost all those field studies that you see cited today used OTO, and they all use less than 1 ppm total chlorine by OTO. And so some of those early studies that you're seeing flaunted around right now, you would get your facility shut down if you ran it the way they did, and they set some of the health standards on those. Then there was a lot of emphasis on Staphylococcus, and even I brought that up about 20 years ago, but staph is not a recreational water organism. But the other germs we figured out, Pseudomonas, we figured that out was a major pathogen once hot tubs came around in the early 1980s. There was even a huge conference on it. Cryptosporidium, nobody cared about Cryptosporidium until that great big drinking water outbreak in Milwaukee in 1993. And after that, people started looking for it because they got money to look for it from the federal government, and they found crypto everywhere. It has probably been here for everywhere. We just are now aware of it. Same thing with Legionella. Nobody really knew that much about Legionella in recreational water until that big outbreak on a cruise ship in '94. And then E. coli, there was that whitewater outbreak down Whitewater Park outbreak here in the Atlanta area in '98. Nobody thought that particular strain of E. coli was a serious strain. And now we realize that and Legionella are the 2 most deadly strains in recreational water. But again, they're chlorine sensitive and they're very rare. Next slide, Jim. All right. What do we know about germs? Where do we get the information? Well, we get it from 2 sources. we get it from the medical journals, and that's like somebody comes into the ER and they're sick and they culture it and they figure out, oh, well, maybe you got it this way or that way, and we think you got it from a swimming pool. But the ER doctors never go out to investigate what really happened out there. So if we had somebody like Lauren's on here right now, if they would have called up Lauren, she would have gone out, investigated the pool. But that hardly ever happens. So you get these medical journals that are cited, and they'll say some things that are rather outlandish. But then you get the reports from the CDC, and they come out every couple of years, and they started in 1978, and they give you these big overviews. But it doesn't give you the detail on really how that pool was operated. And for instance, Pseudomonas is not a reportable disease under the national guidelines. So there's almost no data in the CDC on how many cases of Pseudomonas there really are. And we know that probably outnumbers everything by at least 10, if not 100. I personally believe from what I've read, we probably have millions of cases of Pseudomonas, most of them in residential pools, most of them homeowner run because they're too cheap to put in chlorine.
Hey, Roy, I hate to interrupt, but I do have a question on that. Why in particular is Pseudomonas not reportable? What's the standard by which they call it not reportable?
It's
Who are we
not
speaking to? Can you introduce yourself? We can't see your name.
Yeah, I'm sorry. This is Ronnie Barrett. I'm here in Atlanta, Georgia.
I'm going to stay outside the parameter and stay out of Atlanta. I'm up here in northeast of you. Anyway, it's not classified as a reportable disease by the CDC because it's not considered a major public health threat at this time. It should be, but there's a list of about 50 species on there that are considered nationally reportable, and that includes like measles and things like that. So, but Pseudomonas is just not on the list, so it's not tracked. Is
it just that you think that maybe it's just because there aren't enough reported cases, or that there's not enough data?
It's probably because the disease isn't serious enough.
Got it.
Everybody on this phone, everybody on this right now has had Pseudomonas multiple times. The little red dots underneath your watch band and things like, we've all had it.
Yeah.
It's pretty minor, but it's the most prevalent one, and we're just not tracking it.
Okay. Thank you.
Right. And then there's a couple of specialty studies. The CDC a few years ago went out here in the Atlanta area, and they got jurisdictions to submit formed fecal accidents. Yes, we're talking about the baby Ruth floating in the pool, people. And they took that back and they collected it, and they figured out, and they did analysis on it, and they figured out about 4.4% of that had Giardia in it. And that's where that famous 4.4% came in. I don't know whether that number is accurate or not. I don't know whether it's biased to pool people, against pool people, but that's the number we've got. And then they went out a few years, about 10 years ago, and they sampled backwash samples, and they did it by PCR, and we found all the germs in there, but we don't know whether they're alive or not. So what we've got here is an incomplete set of data. A lot of work, but it is not really what you want to know. Next slide, Jim. All right, why don't we have more? Well, the attitude has generally been chlorine works. So if it works, it's a waste of our time and our money to go out and do the studies. And so the attitude is, if you test by the FAS DPD or the DPD and you got 1 ppm, nobody's going to test for the germs. The attitude in microbiology, if you go into a university, it's like, well, there's no real reason to do this because we think UV or ozone are killing it, and the CDC says there's no really outbreaks, so you don't see too many academics testing for swimming pools because it's just kind of a geeky little field off by itself. And since obviously I'm saying I'm a little geek on this one because I'm the one that's been doing some of this stuff in here, but not many people are interested in it. And then fundamentally, when a company looks at it or a university looks at it, there's no money from the federal government to study it. And a company would much rather spend the money on making a new product than they would on doing something that they don't think is an issue. So there's no motivation from anybody right now to increase our database. It's just not happening. Next slide. All right, so how fast should chlorine kill? All right, this is the federal guideline, the OCSPP 810-2600. Years ago, it used to be called DIS-TIS 12. Where did it come from? Jen, just start clicking through the buttons on this one. It all depends. Are you talking about a swimming pool or are you talking about in a test tube? Because in the test tube, it says you kill E. coli at 30 seconds, but Enterococcus at 2 minutes. So if you've been told everything has to be killed in 30 seconds, somebody didn't get the whole message, because they said right there in the EPA document, not everything is killed in 30 seconds. But then it also says swimming pools are handled differently. You don't measure the rate of kill in a swimming pool. You go out and measure how many bacteria there are. And if it's less than these numbers that are here on the bottom, the pool is considered safe. But guess what? Those kind of numbers came out of drinking water regulations and are not necessarily reflective of what the true threats are. It goes back into that 1950s, 1960s, talking about drinking water. So this is where we are with the federal regulations. It's a little bit disappointing. I've run this particular test hundreds of times, both in the field and out in the laboratory. So that's why I know this one inside and out. Next slide, Jen. All right, so how many bacteria can you have? Well, we have federal guidelines on E. coli and Enterococci and Shigella, because it's another type of coliform. We have no regulations on norovirus, none on Giardia, none on Crypto, none on Legionella, and none on Pseudomonas, period. Okay, so now we're trying to set a limit on how safe water is, and there's no federal concentrations that are set on these things. Make you feeling a little bit more comfortable at this point? I hope not. Next slide. Okay, the idea is that there should be a fast enough rate of kill that if you're in a pool and you're swimming next to me or Jen or Tom or Rudy, and one of us has one of those fecal accidents or whatever, that the germ from us shouldn't jump to you. And it also should be fast enough that if you get Pseudomonas coming in rainwater or coming out of the garden hose, it should kill it before it sets up biofilm. But nobody's ever calculated how fast germs actually get from one person to the next. And they've never calculated how fast germs form biofilm. So what we do is we estimate this. So this is where we develop a mathematical model. And an estimation, you can see what I call it here, it's scientific wiggle word for an informed guess. And that's where we started developing the model for how fast Giardia gets killed. Next slide. All right, there's a couple of ways germs get in the pool. You either bring them in feces, and you have a big accidental diarrheal release, or everybody carries just a little bit on their backsides. And when you get in the pool, that gets washed off. Well, if you've got a diarrheal accident, you've got a problem. You've got to treat that. But if you have 500 people get in your pool and each one has got 0.14 grams, at the end of the day, you've got some feces in there. But how much? The best pool study that's ever been done that we know of is the Pinellas County study done back in '93, I think, Tom, anywhere. And we've got really good data on there. But the way the model was built that we're going to talk about, the Giardia model, is you take that 0.14 grams and you say that's got E. coli in it, but we don't know how much Giardia is in it. So some people carry Giardia, So we apply a guess factor from that to multiply by the feces. And then we estimate how fast the water gets from one person to another. And then we estimate how much water you ingest. And every time you're putting one of these estimates in there, you get uncertainty. That's where the model is that's predicting Giardia. Let's go to the next slide. I think you're up, Tom.
I was going to talk to us about when we look at efficacy, what other terms we need to consider.
Right. So we want to define the different types of chlorine that you're dealing with in the pool. We talk about the chlorine when cyanuric acid is present. Some of the chlorine is bound to the cyanuric acid ring, and we call that the CBC, the chlorinate cyanurate bound chlorine. And that actually is present as several different compounds in solution. Those compounds dissociate rapidly to release hypochlorous acid. If some of the hypochlorous acid is used up by reaction with chlorine demand. And so we know that hypochlorous acid is in rapid equilibrium with hypochlorite ion, the same way you have hypochlorous acid is in equilibrium with this chlorine bound, or the cyanurate bound chlorine. It's a very rapid equilibrium. The chlorine basically bounces on and off. The part that's bound, we either call bank chlorine or reserve chlorine, but that equilibrium is very fast and attaches and releases within a very short time frame. And it's so fast that you really can't measure just the hypochlorous acid. You measure both. The chemistry is a little more complicated than maybe you've been instructed, and we'll get to that in a second. And in fact, there are several compounds in solution, and the equilibrium is governed by several different equilibrium constants. These have been published. O'Brien, back in 1974, measured a bunch of them. Much more recently, Wamman and co-workers measured the temperature dependence of at least a couple of the ones that are important for swimming pool conditions. Next slide. The diagram on the right shows the different compounds in solution. There's several different compounds in solution, 10 different compounds that are chlorinated iso, that are isocyanurate species. There's equilibrium constants, all the different Ks are equilibrium constants which govern the different concentrations in solution. If one of those change, the equilibria adjust and all of them change. And so in order to calculate how much is there, you really need to do some serious math. It's several different equations, simultaneous equations you have to solve. And so the math does get a little complicated there. Next slide. This shows some of the equations you have to solve. So each of the equilibrium constants is defined by an equation. You have to kind of guess how much hypochlorous acid you have, and then do these calculations. One of the issues that we'll talk about later as well is that the two papers that have been published on the equilibrium constants disagree somewhat on what those constants are at basically room temperature conditions. And so of all the different parameters in the model, you would think the chemistry ones would be the most well-defined, but in fact, in this case, even the equilibrium constants aren't particularly as well-defined as we'd like to have. Next. So let's define the different kinds of chlorine that's in solution. The MAC defines free available chlorine, or FAC, as the total of hypochlorous acid and hypochlorite ion. However, what you measure, the available chlorine that you actually measure with the DPT test kit, can be very different. And we have defined a term in one of the change requests noted at the bottom there called DPDFC, and define that as the reading that you actually get from the DPD test kit. And that includes free available chlorine, hypochlorous acid, and hypochlorite ion, and also the available chlorine which is bound to the cyanuric acid ring. And in fact, when you have a pool with cyanuric acid stabilizer in your pool, DPDFC and FAC, the free available chlorine, are two very different numbers. And unfortunately, the MAC confuses that and often uses the FAC where they really mean DPDFC. And that is confusing. So this change request tries to eliminate that confusion. We've also defined what total chlorine is, and combined chlorine being the difference between the total and the measured. And those were actually not defined in the MAC before as well. And of course, the combined chlorine really is there as inorganic or organic chloramines, and they should be limited to 0.4 parts per million or less. Next.
So before we move on, just so you know, we're going to be referring to these terms as they're defined here from this point on forward in the presentation. So just be mindful of that. We're going to be talking about, DPDFC a lot, and by that we mean measured free chlorine, as we just detailed it to you. Okay. Okay. Rudy, I'm seeing a lot of activity in the chat. Before we move on, I just want to say we are about halfway through the time frame that we allotted, and we're basically only a third of the way through the slides. So I want us to be mindful of time, but I also want to give you guys a chance to talk. We are hoping that some folks can stay late, but we want to make sure we get through some of the material as well. So is there anything in the chat, Rudy, that you think we should address or that we aren't going to be answering in the slides to
I think
follow?
we have it covered at this point in time. There was some brief discussion, some side discussion. We're getting them answered between Roy and myself. Craig's helping out, so is Lauren and others, so we're okay over there. I'll keep you posted.
Okay, great. Okay, so we've been talking a lot about chlorine chemistry, and we've been talking about the standards, and here's some information about the two standards we've mentioned to you. PHTA's ANSI Standard 11 and the Model Aquatic Health Code, the latest edition that's currently out that's being proposed changes on is the 2018 edition. And then you also have your labeling instructions on that are regulated by FIFRA on your EPA labels. And these are just showing the different free chlorine, and it is saying FC because that is what's written currently in these standards and on those labels. But I just want to point out that, for the most part, that's really DPDFC, because the EPA, PH Standard 11, and the MAC is not really necessarily distinguishing those. So what they're really talking about is DPDFC, but they could be talking about FAC as we've defined it. And so you'll see the wide variability. A couple things I want to point out here is that you're going to hear about this ratio concept. We're going to talk about that. But when you look at these two codes, you'll see that the ratio of cyanuric acid to measured free chlorine, that's the maximum allowed, which defines a minimum disinfection level. And like I said, we're going to talk about this. In PHD Standard 11, currently that is, why do I not see cyanuric acid of 100 parts per million on here? Did it get cut off?
No, it's you raise the chlorine level if it's over 50.
Okay. But there is a limit of 100, correct?
Yes, there is.
It's not on here. Okay, so I apologize that that's been left off. There is a limit for cyanuric acid, operational target limit of 100 parts per million of CYA. It's not on here. But the maximum allowable ratio for a PHTA Standard 11 is kind of done at a two-step staircase level. But the maximum, if you look at 2 parts per million as a minimum, if you have any CYA, that's up to 100. So you're looking at a maximum ratio of cyanuric acid to measured free chlorine of 50:1, as opposed to the MAC, which again, I apologize if this was left off, but the cyanuric acid target operational limit there is 90 parts per million maximum. And so that's going to equate to a 2 part per million measured free chlorine. 90 equates to a 45:1 ratio. Just bringing that up because it's going to be relevant later.
Jen?
If anybody there wants to take this, Jerry Wallace is
Yes,
asking
I got it.
how. You got it?
I got it. Jerry asked a question about what's the, where did the 10 ppm limit come in there? And nobody's really done a whole lot of research on that. Florida typically used to have a 10 ppm. I think Bob Vincent's trying to lower it a little bit right now. But there was a famous experiment done about 25 years ago that Neil Lowry, if anybody remembers him, chlorinated a pool up in Toronto. It was his own backyard, and then threw his 2 kids in there, and they swam around for about several hours in 12 ppm. And they got out, and if you know his kids, they're both still doing really well. So there really is no rational limit other than the EPA never really assessed that, but they thought there might be some disinfection byproducts that went up, but nobody's wanted to pay for that study. And so it really goes back again to that upper limit is coming out of drinking water. And then in Florida, where it rains a lot,
Roy, the 4 part per million limit.
the 4 part per limit comes out of drinking water standards. The 10 part per million comes out of Florida, where it rains a lot. But, you know, from reviewing the literature, we don't see a whole lot. And I can tell you that 2 years ago, before I took over my HOA pool, I had one weekend where it was running 25 ppm and the pool was full and didn't get a single complaint. Of course, I took over the pool the next year and fixed that problem, but that's a different story.
So I just want to point out, Roy brings up a good point. And thank you for asking the question. It's a really good question. So there's not enough research that's been done on the 10 part per million limit, which is technically, I have to say this, it is technically illegal because EPA is the legislation, is the regulatory aspect that you must comply with. You must comply with the label instructions for use. And those instructions include 4 parts per million maximum limit of measured free chlorine for pools and 5 parts per million for spas. However, as Roy points out, those are based on drinking water. So they're limited to that because of drinking water data. And I'll just say this, you don't go to your pool to drink the water. That's not why you're going to a swimming pool. So, or a spa. So, you know, they are looking at sort of trying to reconcile that. And that's why you see that the MAC currently allows up to 10 because they recognize that that's for drinking water. And they sort of caveat it by saying, you know, you have to follow your label, but it's kind of the CDC is working with the EPA right now. They're in conversations to get this reconciled so that most likely that 4 part per million is elevated based on EPA labels. That could be a ways off. The EPA is slow. So, okay, good question. Okay, so we talked a lot about minimum disinfection in terms of keeping bathers healthy and our pools clean. And we talked about the differences. Well, currently the 2018 MAC, which we're going to talk about, this is the focus of one of the current proposals on the table, is looking at changing the minimum measured free chlorine limit from right now it's set for 1 part per million when you don't have any cyanuric acid. And if you have any cyanuric acid at all, it has to be a minimum of 2 parts per million. But that's really inconsistent. Let's talk about where it comes from. It's based off of an Esterman study, 1984, that looked at a broad range of measured free chlorine. And there was no clear cutoff in terms of, you know, seeing bacteriological quality get out of control. And they had their acceptability criteria on the microbiology was based off of what's pretty standard, I would say, although there is no established criteria in the MAC. And that criteria is very consistent, if not identical, to the microbiology control criteria in WHO, the World Health Organization standard. So, but it's not very clear. And so the MAC cited that you had to have this much free chlorine, FAC, based on that. And So to say that you truly need 1 part per million of truly free chlorine, FIC, to maintain acceptable, microbiological control is just not true. And measured free chlorine, DPDFC, is really what it should be.
Okay, so we have a couple of questions that popped up. We have Joe Footen wants to know if that's the same for a splash pad. The Model Aquatic Health Code, or does anybody know?
Yeah, on a splash pad, though, that's considered an increased risk venue. It will require a secondary disinfection system, either UV or ozone, in addition to chlorine.
Okay, and we have Jules is asking, doesn't the amount of CYA in the pool automatically change those ratios? And I think that's coming up, correct?
Hang on, good question coming.
All right, there you go.
All right, Tom, take it away.
Okay. We're going to present a little data from Pinellas County study, which is a study on actual pools in use. And so this was done, like Roy says, quite a number of years ago. We did almost 500 pools were studied, and basically this is part of the inspection of pools. So the operators are running their own pools during the normal unannounced visits from the public health unit. The pool water was sampled. They did all the readings for all the different parameters at poolside. And then they also scored the pools for type of algae and how much algae was there. So they measured 10 different water parameters. The water samples were taken back to the health department lab and tested for 4 different types of bacteria. And then all of this data was put together and analyzed statistically by accidental chemical. Wrote a very long report that was issued in 1994, but that really just looks at all of the different relationships between all the different parameters in a pool, and that teaches us what the effect of the different parameters on the bacteria quality of the water. So next slide. Of course, one of the things that stood out as terms of being a determining parameter for your bacteria control was the effect of chlorine. And so this is kind of parallel to what the Esterman study is, but it's a little bit finer data. Of course, we're plotting here the heterotrophic plate counts, which is just whatever what grows up on an agar plate as a function of the measured free chlorine concentration. And each point is the average of a group of pools within that range. And you can see that as long as the DPDFC, measured free chlorine, is 0.4 parts per million or higher, that the results are basically acceptable. But if you get too low, if you get below that 0.4 parts per million, then the bacteria counts start going up. And so that seems, from Pinellas County's data, that seems to be about where the cutoff is at 0.4. Now, we don't recommend running at 0.4 because it's easy to lose that with demand. But in terms of efficacy, that seems to be kind of the dividing line between staying in control and getting out of control. Next.
I just want to point out the brackets denote concentration of whatever is inside those brackets. That's sort of a chemistry thing.
Yep.
That's what that is.
Okay. We also looked at the plate counts versus cyanuric acid because that's what people are worried about. This, what is the limit for cyanuric acid? At what point does it tie up the chlorines to the point where it's not effective anymore? If you take the data from Pinellas County and plot the plate counts versus cyanuric acid, you can see that even up to cyanuric acid levels well above 100, well above 200 parts per million, that you really don't see the counts jump. So you still have bacteria under control even at cyanuric acid levels above 200 parts per million. Where you see the bacteria counts jump is at low cyanuric acid levels, below 20 parts per million, because what you end up with then is an unstabilized pool, and you're running out of chlorine. And if you look at the data, a lot of those pools just don't have any chlorine there. So the real problem is not high cyanuric acid levels. The real problem in maintaining your pool is maintaining some chlorine in your pool.
If I could just jump in for a half a second. For everybody that's on here, do understand that one of the major concerns in a high cyanuric acid level is folks taking that level into consideration in calculating the saturation index and not taking the contribution to total alkalinity out in calculating the formula. That's one of the bigger concerns of a high CYA. But if you're actually considering that when you calculate the saturation index, then you don't have a lot of worries. The concern is in damaging the pool. That's where a big issue would lie. All right, sorry about that, Tom.
Rudy, what do you mean by damaging the pool?
Saturation index basically is for the protection of the vessel, whether or not the water is corrosive or scale forming. We know that about roughly 1/3 of the CYA in the water contributes to total alkalinity, because total alkalinity is a measure of bicarbonates, carbonates, hydroxides, and cyanurates. So we do need to factor that number in when we make that calculation to make sure the water's in balance, so that way we don't screw up pools as we chug along.
Yep.
So we want to keep those looking nice too.
Quite agree, Rudy. You have to make sure you make that correction, and there's plenty of places where they tell you how to do that. Okay, move on.
Now that we've looked at Pinellas, just to, last nail in the coffin on why you really don't need 1 part per million of truly free chlorine. Just to put that in perspective for you, if that was truly meant to be the intention of the minimum amount of disinfection that you would have, you'd be looking at a 0.32 parts per million hypochlorous acid concentration at the highest allowable pH of 7.8 in the MAC. And to put that in perspective, if you were to try to attain a 0.32 parts per million hypochlorous acid concentration with having the maximum allowable 90 part per million CYA, you would have to have 38 parts per million measured free chlorine to get that amount. So to say that you need 1 part per million of truly free chlorine just makes no sense. That's equivalent to the level that you see for the upper level that you would see for the hyperchlorination protocol based on CDC guidance for, accidental fecal release response and remediation. So really, like I said, the greatest risk for infection is running out of free chlorine. And the 1 part per million of measured free chlorine DPD does to ensure that by keeping the pathogens and bacteria under control. And just to note and emphasize again, cyanurate bound chlorine acts as a reserve for the free available chlorine to disinfect. So we've submitted a change request. I just want to point out that is focused only on the 1 part per million DPDFC, and that is that change request there in the bottom that we're recommending that be adopted. Okay, so when we talk about minimum disinfections, it's not just measured free chlorine that we need to consider. There are a lot of other pathogens. There's more than microbiological control that we need to be looking at. And as we've mentioned, we know that hypochlorous acid is the primary biocidal species from available chlorine treated water. And the literature by and large tells us that disinfection kill times, they are directly proportional to hypochlorous acid concentration. They are not proportional to the measured free chlorine for the reasons that we've already discussed. And so there's been all this debate, right, in terms of we know cyanuric acid lowers efficacy, and we know that that hypochlorous acid is the key, but we also know that measured free chlorine isn't part of it. So there's sort of been a disjointed, so we've been sort of hovering on some information, and CDC and CMAC board appointed specific people to try to work on the science to do this. And that group of people has been working on that for the last 5 years. we talked about this the last time we met, which was now a month ago. So this is the exact same slide. Just the memberships that make up, the folks that make up the membership of the CMAC Chlorine Stabilizer Ad Hoc Committee, or let's call them the CYA Ad Hoc Group. And Tom, Roy, and myself have at some point served on this group. And Roy, but the membership has changed. I just want to point out a couple things. We talked about this before, but it's really important because you hear all this commercial interest and you hear, you know, different backgrounds give us different insight levels on these different topics. And the original membership was specifically designed to allow for the appropriate expertise that was needed to do this work and balance. Okay, and both of those were absolutely critical, in my opinion, for this group to be successful. And you'll notice that the membership has changed, which means that expertise and the balance have both been impacted by that. And I'm not going to get into a ton of details. It's all here. You guys can refer back to it later. But the blue folks are the ones that are currently still members. So, okay. So this group, like I said, the membership changed, but ultimately their work of 5 years culminated in this peer-reviewed paper. And the peer-reviewed paper has basically 3 parts to it. It has, you know, talking about hypochlorous acid and the ratio concept. It developed a model, which is that informed guess that Roy mentioned to you earlier. And then they went and took the model and used it by making assumptions and putting inputs in it to give their best recommendation on a max ratio or minimum disinfection level. So one of the important conclusions, and this is the ratio concept, and I received some feedback you guys are interested in hearing more about this. So as we mentioned earlier, these 2 conclusions about disinfection rates we talked about are well established. Well, this publication took it a step further and said, it's not inversely, disinfection is not inversely proportional to high cyanuric acid. In other words, you can't say it's true to say that disinfection linearly goes down as cyanuric acid in a linear relationship goes up. So that's not true. It's proportional to the ratio of cyanuric acid to DPD-FC. And the reason why that is because DPD, the ratio is proportional to hypochlorous acid concentration. So that ratio or hypochlorous acid concentration is what governs the disinfection rate. You're going to hear a lot about that, and that's where this comes from. We're going to show that. But this model, we're not going to get into a lot of the details today, but we did review them last time. There were some assumptions that were made. And so if you make the adjustments to a more reasonable worst case, it really shows that really all you need is less than 0.03 parts per million of truly free chlorine to effectively control a lot of the chlorine-sensitive pathogens and bacteria, including Giardia. And there's a lot of assumptions, a lot of being made on that, and there's a lot of uncertainty in that. We're going to talk about that as well. But we're not proposing that that's the limit, just noting that that's the case.
Jen, I'm going to ask that Jules asked a question, and I'm going to ask her to jump on it if she could just ask that outright, Jules.
Hi, yeah, this is Jules. I was just wondering if when this model study was performed, was that done in a variety of regions? Was that with, in Florida and then also in the Midwest and all the way into California, or was that just done in one particular region and one particular climate?
So this group of authors did not go out and take data from pools directly or anything like that. So there wasn't a geographic region, but rather they extensively combed the scientific literature that's out there, data that's been published, and utilized that data, which comes from all over. Everything they could get their hands on in the literature. They did a pretty extensive search to generate this model and generate these estimates. So I don't know if that answers your question, but it's not a specific region. Roy, you look like you want to say something, so I'll let Roy talk. You're muted, Roy.
I'm only asking because obviously the model would need to vary from region to region. So thank you.
Right. Yeah.
Roy actually made a comment in the chat box on this.
Yeah, what we want to point out on there is, when I was talking about all the data gaps we've got from the real world. Well, what we've got here is a model that was done on a computer, and it was using what information we readily had. But then if we go back to that original 1963-64 US Department of Agriculture instructions, they say after you do the laboratory, you have to go to the field. This has not been verified in the field. There is no data from the field that definitively supports or refutes the model. So it is a computer estimation based upon the limited data that we have.
Okay. So the last point I wanted to make with this slide is that, you know, we are not saying that the ratio is the end all be all, but rather that we need to look at the ratio in addition to looking at these limits separately. So we are saying that 1 part per million DPDFC should be your minimum, but we're also saying that another way to address minimum disinfection in addition to that, not separate, but in addition, is looking at this ratio concept. And we'll also talk about cyanuric acid levels as it pertains to adopting a ratio as well.
Hey, Jen,
So-
can I ask a question?
Yeah, hey, Craig.
Hey, and this is kind of for Roy, I guess, because he was just talking about, so you said that it needs to be, it needs to go from the lab to the field, but it sounds like this hasn't even been tested in the lab. This is just something that they came up with by reviewing studies. Is that correct?
It's not 100% correct, right?
Yeah, it's
Was
kind
there
of
an actual lab study or?
It's not really a lab study, but it's taken from a lot of laboratory data. So there's been a lot of basis in the laboratory. And so in that case, what you can do is you can take the laboratory data and combine that and come up with it. So I would say that there's a significant quantity of laboratory data on
Okay.
how free chlorine and cyanuric acid work. But there's a couple of holes. For instance, there's no data on Giardia. So the model works very good on bacteria, but does it work on Giardia? Because we don't have data on Giardia. So it's kind of a combination of a little bit of really good knowledge and a lot of guesswork.
Cool.
So
Thank
I'll
you.
just add that there's a lot of different components that went into this model, including like exposure assessment, like how often does somebody go to a pool? What, you know, because you're trying to estimate the probability of their annual risk of infection, right, of these various pathogens. And so, you know, that being considered, there was other peer-reviewed data that's not just lab generated. It went out and looked at pools, you know, how often is a child in the pool? How often is an adult in the pool? How much water do they ingest? And so there was pool data. There's a whole bunch of different aspects that go into this. It's not just about chlorine and cyanuric acid chemistry. There was a lot of inputs, and we'll touch on that as well a little bit more, but not at a very high level. But we will talk about it. So when we're talking about this ratio concept, I mentioned to you guys earlier that PHTA standard 11 has the equivalent of a max ratio of 50. They're not managing as a ratio, but if you take their upper limits, that's the maximum allowable risk per the target operational limits in that code. And then for the current model aquatic health code, that max ratio is 45:1. And you'll notice in both of these instances, as you see the DPDFC vary and the cyanuric acid concentration vary, you'll notice that as long as that ratio of cyanuric acid to DPDFC stays the same, regardless of how those cyanuric acid and DPDFC concentrations are varied, the hypochlorous acid concentration is constant. So the ratio is constant, hypochlorous acid concentration is constant. And so that is where this is coming from. And so when we look at these proposals in terms of a maximum ratio, no one's saying that you should stay at that ratio per se, but rather have that be a maximum target, just like you would consider the 100 part per million of PHTA standard 11 a maximum. You're not saying that you should keep your CYA at 100, but that you shouldn't go above it. And so there's been some misunderstanding by some folks that this ratio, they have to stay at a ratio of whatever that ratio is, but it's a maximum, it's a limit. The ratio is a limit, okay? And this CR that's mentioned here at the bottom, there's a lot more explanation on this in that CR, and I just put that there as a reference for you. Okay, so I mentioned to you there's a lot of inputs that went into that model. This covers quite a bit of it. I just want to point out a couple things in this model. And we're not going to review all these. I just put it as a reference point for you all. The factors that are in green are what's considered input parameters in the model. But these are all different types of things, and it's not necessarily an exhaustive list of everything that can affect disinfection and efficacy, and therefore your risk of infection. The items in yellow are the ones that were adjusted based on making a more reasonable worst case than the original paper put out. So there were some unreasonable and unrealistic assumptions made for those items in yellow. In particular, the diurnal recovery hours of operation, it was assumed that the pool was going to be open, never closing, 24 hours a day, 365 days a year, because the model didn't have the capability to account for that. That was added after the model was published. But we're going to talk a lot about pathogen introduction rate parameters, because that is the critical turning point for this model and its ability to estimate risk, because it combines how much fecal matter there is that's being introduced to the pool per person, how much of that fecal matter contains what concentration of pathogen, and what concentration of pathogen is viable, what is likely to result in infectivity. And so these things are very, very, very complicated, and there is hardly any data out there that can give us accurate information on that. So Roy talked to you guys a lot about different pathogens, and when we look at the different pathogens that contribute to outbreaks, some things to notice is that there's basically a couple different categories that they can fall into. There's ones that are introduced from the environment, and there's those that are introduced from people. The ones that are introduced from the environment, they do reproduce in water. This means that they can grow in water without, on their own, without any further introduction from the environment. Those that are introduced shed by bathers are reproducing only in people, in their host. And so they will gradually die off. So basically environmental ones are more opportunistic, and those that reproduce in people are more obligate pathogens. And so we kind of have to look at the risk with those a little bit differently. The other thing I want to point out here is that, Cryptosporidium, when we look at this chart that has different CT times, and Roy talked to you a little bit about that in terms of that's lab generated kill times. But you'll see that Cryptosporidium is ridiculously off the charts, right? And that is why we see so many outbreaks with crypto. That and a few other reasons, but that's basically the biggest reason. So it's not reasonable to try to control a pathogen which is clearly not chlorine sensitive with chlorine and cyanuric acid.
That's actually about 10 and a half days, is it not? 15,300 minutes.
12.75 days, Rudy.
How many?
12.75 days.
There you go. Oh, look at that.
There we go.
Hours, excuse me. Yeah, 10.7.
Sorry, my rounding might be a little off there. Just want to point out that the model focused on Giardia because crypto, well, it looked at E. coli, Giardia, and crypto. But then in addition to that, it said, well, when we talk about making a recommendation for code and how we should set a routine ratio, minimum disinfection to max ratio, we should not choose it based on crypto because that's not a reasonable thing to do for something that's not chlorine sensitive and for something that's from accidental fecal release, not necessarily routine operation. So they chose Giardia because it was a much hardier pathogen. You can see it's not chlorine resistant entirely, but it is more resistant than most, certainly. And they decided that that would be the highest risk routine pathogen in pools from gastrointestinal illness. And that is where that came from. And that is an assumption that's being made. There is no data, as Roy explained to you all, to validate that assumption. And that's a new conclusion. So when we talk about these assumptions that are being made, this model does a really good job of a way to computationally estimate risk, and then look at what those ratios correspond to. But it has a lot of sensitivity to it from various input parameters, as I mentioned to you, which result in a wide variability in the results. And that means just basically large uncertainty, large sources of error. So there's a lot of proposals that are being made to reduce the risk based on what is currently in these codes. And as it pertains to the MAC, these risk reduction proposals they're just not justified. The uncertainty is too large, and we're going to talk about we're going to show you what we mean when we say it's too large, based on this model. And we're referring to proposals that are for ratios that are less than the current maximum allowable, which is 45:1 for operational, and anything that's trying to convert a current operational target into a closure, imminent health hazard closure criteria is just not justified either. These have significant notable industry cost and operational impact to them. And some of that has unreasonable and unrealistic assumptions being made. The problem is that these risk reduction proposals that began with this paper really set the stage for this misconception that risk reduction is warranted, it's needed, that it's a reasonable proposal at this time, despite the large uncertainty. And we've learned a lot since that paper came out, and there's been a lot of criticism. But the ratio concept itself is strong. The science behind that is there, and no one's refuting that. So I just want to point that out as well. But there's still issues with how that's being received, and the fact that this ratio concept is not understood yet. Folks still believe that they need that minimum 2 parts per million if you have even 1 part per million, 2 parts per million measured free chlorine if you have even 1 part per million of cyanuric acid. And so obviously there's an educational barrier and misunderstanding, and so these proposals are sort of reflecting that as well. All right, Roy, take it away.
Okay, now we've talked about there's a lot of uncertainty in that. So, I mean, it's like all of us own a test kit. So let's just say that you're on Amazon and you see this brand new test kit comes out, and it's blue with green stripes and purple polka dots on the box. That way you know it's not from anybody else and it's coming in from Mars. And you decide that you're going to buy this test kit because you want to see whether it's really good or not. And you open the test kit up and it says it's plus or minus 585%. Now you're going to find out whether this test kit's good. So take your old test kit out and measure your calcium hardness, and you get 260. Okay, all right, you know, your pool looks balanced, right? So now take your striped purple polka dotted test kit out, and your first reading, you get 1521 ppm. You test it again and you get 44 ppm. What's wrong with the test kit? Nothing. Why? Because that test kit manufacturer told you that it was plus or minus 585%. Both readings are within manufacturer's specification. Jen, there should be 2 more bullet points on that one. Would you buy the test kit again? Guess what? The uncertainty on the amount of Giardia in the water is 585%. Do you think we have enough data based upon what we know to actually make a scientific calculation? If you won't do it with calcium hardness, are you willing to say this is good enough to tell you what the level of cyanuric acid should be? The ratio is solid, but what is the limit? The limit is specified by how much Giardia is in the water. And if we don't know how much Giardia is in the water, why the hell are we spending so much time talking about what the limit should be? Wouldn't it make more sense to go out and get the data like you're supposed to in science? And if you hear my frustration, that's why I'm pissed off about this whole thing. This is what the problem with the model is. It's plus or minus 585%. Tom, you can explain now where the graph comes in.
Okay,
I'm gonna take that one, the graph.
go ahead.
All right, so thanks for priming me there, Roy. So what he's talking about is specifically related to Giardia shedding rate. So the lead author on this paper performed a statistical log normality on the model's capability to estimate risk for any given curve. So that means any given risk curve that's generated regardless of the other inputs. So outside of Giardia shedding rate inputs, the other input parameters like bather load, hours of operation, how much filtration you have, that sort of thing. You set all of those sides. You can choose any grouping of that you want, okay? And then any curve is going to be generated from that. But the Giardia shedding rate has an uncertainty of plus or minus a factor of 5.85. So when we decided to graph this for you, just to show you what that looks like, we took the worst case conditions that we adjusted from the original publication to make them more realistic and more reasonable. But like I said, you can do this with any risk curve that you choose, and you're going to see how much it varies. If you adjust the Giardia shedding rates by a factor of anywhere between 1 and 5, you're going to see that if you don't adjust it, it shows the ratio of 45 to 1. But if you go down to half, it doesn't necessarily equate to half. And if your shedding rate is off by a factor of 2, then you're looking at 17.8 as your max ratio. If you go to a factor of 5, your max ratio is 7. And if you go to a factor of 1/5, let's say your Giardia shedding rate's off by a factor of 5 too high, then if 1/5 of that means that you're never going to reach the risk level of concern. So your ratio would always be acceptable. There is no max ratio. So obviously this variability is unbelievable.
If it comes back to this, if you've got that much variability on your calcium, would you accept that as a test kit? If you won't do it with something that doesn't impact public health, why the hell is anybody saying this is a valid model to talk about something that actually impacts our lives?
So basically we're saying it's impossible to use this model to estimate the acceptable ratio reasonably accurately at this time. I'm not going to go through all this on this slide, but you're going to hear a lot from various folks about relative risk reduction. And so it's really important to put that in perspective when they talk about relative risk versus the actual risk or absolute risk or just risk in general. The relative risk is what the difference is in risk, okay? And so the model does do a pretty good job of estimating the relative risk differences. The relative risk is the difference between scenario A, the risk at scenario A, versus the risk at scenario B, the delta in between those two, the difference. That's your relative risk, increase or reduction. And so a lot of these risk reduction proposals are saying you can reduce relative risk, you can reduce risk. And what they're saying is reduce risk relative to what it is now. But this doesn't really have any meaning when we don't understand what our actual risk is. I mean, in that previous slide, we showed you how much variability there is in the estimation of risk itself. So how can you say that we need a risk reduction or that the risk reduction is giving us anything if you have no idea where that risk level is because of this large uncertainty? If your risk is already so close to 0, then a factor of 2 less than that is no benefit, no real benefit. So that's basically all this does. Okay, so I mentioned to you guys this committee that did this work. And I kind of wanted to talk about where that committee sits. And these are considered to be the experts that the CDC personally handpicked, okay, for this work. And they agree on the ratio concept, that should be a part of how we look at managing disinfection in our recreational water. But they also recognize that there is a good amount of uncertainty and that we do need to do more research to minimize this uncertainty. However, And they also recognize that we don't have a lot of information right now to go off in terms of determining a minimum disinfection requirement in the form of a max ratio for imminent health concerns for closure. But even though they agree on all of those things, there is disagreement on whether or not we have enough confidence to try to justify risk reduction proposals now, which we know result in operational costs and impact to the industry. And so that is where things currently sit. Some things that you might not know that they won't be likely to tell you is that the paper originally stated that there was no significant financial or operational impact to the industry. However, they did not look at water replacement costs in certain scenarios, and they have determined since then that it's not as insignificant as they thought. However, there is, like I said, there's still disagreement on whether or not they can still justify the risk based on this. And the truth is, the ratio that has been supported by the majority of these committee members has changed countless times since that paper has been published and even before it was published. But the one that has been favored the most frequently has been a ratio of 45:1. And that is, there's something to be said about that. And this is relatively close to, like I said, the PHGA's standard 11, 50:1. On July 31st, the CDC got involved with this committee, and it was communicated that the only ratio that the CDC, who owns the Model Aquatic Health Code, could support at this time was a ratio of 45:1. That was undone the following week. So if this gives you any idea, these experts aren't sure, and obviously the CDC is not sure. And when they changed it, they had a vote on two different options of a 30:1 that was going to be put out by this committee by vote, or 45:1. And they told you that they reached a vote of the majority with only one dissenting vote, which was Tom Kuechler, in favor of the 30:1 with only one dissenting vote. What they don't tell you is when they voted on those two options, the vote was split 50-50. Half of them wanted 30:1 and half of them wanted 45:1. These are your experts. So moving on from that uncertainty, we're going to switch gears here and talk about moving on from the ratio concept, how this affects CYA limits. Okay, when we adopt a ratio, we mentioned that we want to do that in conjunction with free chlorine limits and cyanuric acid limits. But now that you have this max ratio in place, you don't necessarily, it wouldn't make sense for you to stay, for example, at 90 parts per million cyanuric acid, because then you have to have a minimum of 2 parts per million. So if you increase your free chlorine, you can still stay below a max ratio of 45:1 if your cyanuric acid levels go up. And so this change request has been put in, that's mentioned down here, to elevate the cyanuric acid concentration from 90 to 180, because that 180 corresponds with a free chlorine limit of 4. And you're still maintaining below that max ratio of 45:1. We're not saying operate at 180, but we're saying that based on maintaining below a certain max ratio, your cyanuric acid levels should now be allowed to go higher if you need them to for your facility. So you can do this by testing that. And so this CR was written with the concern that maybe some folks couldn't perform dilution or may not be able to accurately. And so we've addressed that by putting in a procedure that talks about dilution and the ability, and saying that pools with operators who can demonstrate the ability to accurately determine cyanuric acid concentrations by utilizing some sort of dilution or more robust test kit to have cyanuric acid levels up to 180. Otherwise, they have to be maintaining at the 90 part per million limit. Roy, I think this one's yours. You're on mute, Roy.
Hey, Jen, can I jump in with a question?
Yes.
So my only concern with that recommendation is not necessarily about bacteria, but about algae, because just anecdotally, I see more problems with algae forming when our CYA gets above 100. So I kind of like that limit in that 90 to 100 ppm range, just from the standpoint of an operator's perspective and controlling algae. And I know algae is different than bacteria, but algae can also harbor bacteria. So I'm just wondering if you wanted to comment on that.
I'm going to let Roy comment, but I'm going to say one thing first. These codes are written, the more complex you make them in terms of writing them for, oh, this is a high risk venue. So if you have a high risk venue, then you have to meet these requirements. But if you're not a high risk venue, then these are your requirements. So the more we differentiate, the more we see issues. And the MAC Annex is meant to sort of help with some of that a little bit in terms of giving more explanation. But algae is not as much of a health concern, as pathogens are. I mean, it's an important thing to look at. But if we started looking at that, then we have to look at outdoor pools versus indoor pools versus outdoor pools that have an environment that's more prone to, having higher algae because of surrounding, trees and things of that nature. So you start to get into those weeds. I'm going to but that's
Could I jump in for a second, if I could?
And then I want Roy to use our algae.
I'm gonna interject, and hopefully I don't steal any of Roy's thunder here, but just I think what this supports is us being able to look at each pool as an individual pool and the protocol of each operator to work within the guidelines that work best for that person, instead of just saying, okay, this is where it has to be, where you have somebody in Southern Florida who's struggling with maintaining a chlorine level in that range. This gives them the freedom to have a little bit higher of a cyanuric acid level. And just looking at everything as an individual, one of my big mantras is, I always tell folks you have to think outside the pool, and part of thinking outside the pool means that you take the entire environment into consideration. And in your area, that may be more of a concern than in another area. We just don't want to restrict anyone. So we're not saying that you have to go to a higher level. We're just saying that some folks may need a higher level and they can maintain their pools algae free at those levels. And as long as you can, then that's great to stay there. If you can't, then definitely you need to come down. But this is just not restrictive, because we want to look at it like there's not cookie cutter pools, there's not cookie cutter chemistry. There are differences, and we do need to factor those things in. And I think this lends more toward that.
And I also just want to add before Roy chimes in, there's also algicides, which is not necessarily chlorine based. So we can't just focus on only how disinfection is impacted, not from just a pathogen or bacteria standpoint, an algae standpoint. We got to look at other things besides chlorine and cyanuric acid. You've got to look at filtration and backwash and other forms of disinfection and water treatment. And those things are also impactful. You've got to look at what other tools you've got in the toolbox, like various algicides and things of that nature. So I just want to point out, it all makes what makes pool chemistry very complex, as you guys sure well know. Go ahead, Roy.
Yeah, I had multiple outbreaks this summer. Every time we had one of our minor hurricanes come through, half my pools turned green. And, some of them had 7, 8 ppm free chlorine in there with 30, 40 ppm of cyanuric acid in there. And so a lot of it comes in on other factors in there. But the cyanuric acid, yeah, it may be contributing, but the data doesn't show it when we look at the big studies on there. So algae is a complicated issue, but I will correct one thing. A lot of people say that algae is an indicator of other bacteria. There is not a single published study that supports that. That is one of our, based on scientific literature, I'm going to call that a myth. Because every study that we've looked at algae trying to find pathogenic bacteria with it, it's not supporting that idea. So, you may have if the pool is really dark green and everything, and you can't see your hand 3 inches in, that's a different situation. But if you've only got a slight amount of algae in there, that's not necessarily an indication that you have Pseudomonas growing in there and you're going to have an outbreak. But we'll say the other thing, it's like if you have high cyanuric acid, I'll put money on the fact that you have high TDS. And you can get a TDS meter off Amazon that costs about $11, and I carry a couple of them with me on my pool. And I find every time I start getting cyanuric acid levels up, my TDS is through the roof. And so it's a multiple factor that's coming in there. And exactly which one's leading to those algae outbreaks nobody's got the data on that one. But let me give you a little quick background, and I've lived through most of this slide right here. If we look back about 30 years ago on here, way back in ancient history, I think they had about a 200 ppm limit on cyanuric acid. And sometime about 30 years ago, and I can't find exactly when, NSPI at that time dropped it down to 150. And then 2004, I believe, World Health Organization brought out a risk assessment for recreational water that said you shouldn't have more than 117 ppm of cyanuric acid from a health viewpoint. Well, guess what? They got their math wrong on it. So then there was a big knockdown, drag out fight in an RWQC meeting between Ellen Meyer and Karen Rigsby, and neither one of them could agree on it. So the committee met them halfway, and that is where APSP, now PHTA, ended up at 100. It was a negotiated position, not based upon necessarily science, but citing some of this World Health Organization argument that it was 117. We knew it was wrong the day it came out, but it's been thrown in our face since then. All right, then later somebody came along and said, well, if 100 is the maximum and your little disappearing dot test only goes to 100, we should put a safety margin in there. So they capped it down to 90. That's where that came from. Well, NSF International a year and a half ago, put out a new risk assessment. And they said, based on toxicology, it's safe to at least 305 ppm. Now, we know that's NSF. They've got no financial stake in whether somebody's buying trichlor or not, but their risk assessment said it's 305. That's been pointed out repeatedly to people at the CMAC and CDC, but nobody wants to go back up. Are they scared? Do they want to admit a mistake? Or is there commercial motivations behind that? You can decide that. Next slide.
Before we go to the next slide, I just want to point out NSF did this, but what they did was they used EPA's swim model to assess cyanuric acid toxicity, which is very robust. We'll talk more about that. Anybody can perform that calculation using EPA's swim model. And so I just
the way the EPA calculates it.
Right, but they accidentally.
The World Health, EPA.
Yeah, EPA came up with that swim model calculation, and they didn't do it right, and NSF found some errors, and they followed the calculation the way it was supposed to be done, and that's where that 305 comes from. And both the 117 and the 305 both have a safety factor of 100 built into them. Just want to point that out as well. All right, Roy.
Okay. All right. What we get into, and it's the same situation whether you're getting into TDS or calcium or cyanuric acid. It's like a test kit is only validated over a certain range if you're going to do it in a direct meeting. If it's above that or if it's below that, you're not getting accurate results. You know, and if you're using an FAS DPD kit and you only get a little bit of pink in there, are you at 0.1 ppm, 0.05 of a ppm? You can't tell what it is. Conversely, if you're way over the top at 25 ppm or 30 ppm free chlorine, you're not going to get a right reading. And so there's a range that you have to use your test kit over. Bottom line, use your test kit properly. But there are ways to get around this with certain parameters. Next slide. So you can dilute to measure TDS or calcium or cyanuric acid because they're stable when you dilute them. You cannot dilute to measure pH, alkalinity, free chlorine, combined chlorine, total bromine, or ORP, because simply the act of diluting changes the sample that in such a way you cannot measure it. All right, we should be using the test kits the way they say. Now, we're hearing rumors that a couple of the test kit manufacturers are going to come out and with ways that you can measure higher levels of cyanuric acid, perhaps as high as 300 ppm. I'm not saying that you should run at 300, but if you take over some of the pools like I took over this summer that were swamps, you want to know what the real water chemistry is. So the next slide is a way that we might do a dilution with TDS or calcium or cyanuric acid. All right, and this is literally the way I do it. And this is a combination of thinking cheap like we need to be to keep our business down and being practical. Go out on Amazon, get you a 500 mil graduated cylinder there like you see on the left, costs you about 10 bucks. And get you a jug of distilled water from the grocery store. Pour 100 mils of pool water into that graduated cylinder. Add 200 mils of distilled water up to the bottom of the meniscus. We know how to do that. We've all been through the CPO. Stick your hand on top of that graduated cylinder, turn it upside down 3 times, and then run your assay. Now you've diluted that by a factor of 3. So on your test kit, if you get a reading of 30, you multiply it by 3 and your reading is 90. If you get a reading of 50, then multiply it by 3 and you got 150. If you get a reading of 100, you had a whole bunch of cyanuric acid in there, and you probably need to be diluting that pool down there. But this is a simple way you could do it. And once we get these new systems out from our test kit manufacturers, you can throw this away. But it's like, I literally keep this in my service van these days, and I've had to use it multiple times because the pools I got late in the season weren't that great.
I just want to add that he talks about using distilled water, because you guys have probably been trained on that for hyperchlorination remediation. But I want to point out that tap water is perfectly fine for diluting water if you're measuring cyanuric acid. Tap water will do just fine. You will not be introducing any extra air with the use of tap water.
The other, I wanted to just bring up, we started out the conversation talking about diarrhea, not that I want to end it that way, but some folks said they had more frequent diarrheal accidents throughout a season than others. And like admittedly, Craig, for example, has some high risk bodies of water. And although mine were mostly student housing facilities, apparently they behaved, at least in that area. But in that scenario, if you're looking at having a higher cyanuric acid level, and I don't know where you keep yours, but Craig, I'm going to put you on the spot because I know you and I can see you. So if you have, where do you keep your cyanuric acid levels? We were talking about that before.
So, I mean, I tell my guys to target between 50 to 70 is what we like to see, just because I feel like that's an effective range, and because there's a certain amount of error in the testing, a certain amount of.
So let me ask you this question then, pertaining specifically.
We can ask what his free chlorine levels are with those associated cyanuric acid concentrations.
Well, because I didn't care, but go ahead. Where do you keep your chlorine levels, Craig?
We like to have them between 3 and 5, but between 2 and 10 is acceptable. So that's
here's my question. So we know that if somebody has a diarrhea accident in the pool with cyanuric acid in the water, you got to bring that level down now to 15 parts per million. So if you had maintained your cyanuric acid level at 30 parts per million, you're talking about having to drain in the pool 50% and refill it. Once we start to get up to 70, 80 parts per million, how much water are you draining out? And how much do you drain out before you just say, heck it, go the rest of the way, drain it all out, scrub the walls down and refill it without having to go through the remediation process afterwards? So as far as a higher level being a concern, I mean, most of us aren't staying around 30 parts per million anyway. So we're talking about first step, drain more than half the pool. I mean, at that point, I'm just draining the whole thing. I don't know about you, but it's a lot quicker. It's a lot easier, and I'm almost there.
You're getting ahead of us.
Yeah, that, or you just run the chlorine higher than 20 to get it done faster.
Yeah.
All right. I'm sorry. Go on.
Roy, you're still up.
Well, this was that L1, L2 that you guys are pushing on there. Jen, take this one and the next one.
Tom, you're taking this one. Then.
I can take this one. Okay. Some of the critics have said that well, if you dilute samples, where you introduce a more error. Well, that's true, but it's not that big. You can do dilution, and probably if you read your meniscus right, it's probably no more than about 4% in terms of a dilution error, and that's a lot less than the actual measurement error for most of these cyanuric acid test kits. I mean, the MAC does specify that pool test kits have to be certified to NSF 50. I don't know how many people there were in this group actually use a test kit that's definitely certified to NSF 50. But when you do certify a test kit to NSF 50, they certify it to a given accuracy, and they define that as these L1, L2, or L3 levels. And if you go to NSF's website and look at a certification, they tell you which accuracy and which range that test kit is certified to. For example, the Lamont spin test photometer, it's certified to a range of 5 to 50 parts per million, and the accuracy is plus or minus 15% at the lower part of that range, and plus or minus 12% at the upper end of that range.
I just want
to, and that's one of the better test kits out there, and so the error there is a lot bigger than that they're certified to, is a lot bigger than the 4% dilution error.
Tom, do you want to mention that the range that we're talking about is whatever the sample is? So if you dilute that sample, then you've got a dilution factor built into that. But the range is for the direct measurement that you get from however you did or didn't dilute that.
Yeah, you are measuring. This is the range that you're measuring the sample on the test kit.
But it's not necessarily the determinable range by utilizing a dilution.
Yes. Yeah.
I want to throw these in before it drifts too far up the chat, but David Van Brunt asked a question to everyone, and I'm just going to read it as it is. Chlorine enhancers, the X factor, where do these fit in as far as borates, Pool RX, a whole bunch of different brand names? I find that I can reduce chlorine levels by more than 50%, even in pools with very, very high CYA levels. I added in an extra very there. Wouldn't this point to the wouldn't it point that there are more factors beyond CYA levels? That's his question. So where do borates and copper sulfate and those things tie in is what David is asking us.
I could comment on the copper. I mean, there are certainly some literature papers that show there's some synergistic effects between chlorine and copper. And so I'm not surprised that you see some help there. I have not seen any literature on the effect of borate on chlorine, so I can't really comment on that. Other than, borate could be kind of competing with the cyanuric acid to a little extent in terms of holding on to the chlorine. I mean, to me, chlorine, available chlorine, HOCl, another way to look at it is it's a big Cl plus, which is a big soft proton.
Does that work, David? I mean, I know borates also serve as an algistat. So I'm hoping that gets your question answered there. All right, everybody, I apologize.
I think, David, I see your mouth moving, but I can't hear you.
Sorry, I had my mic muted.
There you go.
I was just going to say that, sorry, my hair's all messed up. I think the borate factor is that it's also pH buffer and it's a natural algistat, which makes the chlorine work better. And I think they're becoming more prevalent in the industry using the borate product for that very reason. And as far as the mineral enhancers, I think a lot of that has to do with the same concept that it destroys all the microalgae in the pool before it can form. and therefore the chlorine is not used up fighting it. Same with the phosphate removers and the enzymes. They do the same kind of process. So all of these, I think, are factors that should be considered when you're talking about high cyanuric acid levels, because these are things that a lot of people use in the industry. Homeowners use them a lot also. And these are something that I don't think anyone factors into this kind of discussion.
Certainly anything that reduces the chlorine demand is a good thing. So you just don't use up as much chlorine.
Okay.
And I think the borate factor is something that I think a lot more people are going to start putting in to equations. I know that SenSafe, the ITS company, they're going to add borate to their TDS, to their LSI reading pretty soon with their thing, because borates are so widely used now that they're going to add that to the LSI reading as far as that goes. So
Yep.
I think the borate factor is something that should be introduced into any kind of discussion with cyanuric acid level and chlorine moving forward.
I would like,
Appreciate the feedback. Yep.
yeah, and I would like to talk with you more on that too, but maybe a little bit more in depth, David, a little later on. So.
I do want to point out when you dilute samples, I mean, the percentage error is the same for the diluted sample, but you really have to multiply the error by the dilution factor as well. So if you do the 3-to-1 dilution that Roy was talking about, you go from 50, you give a reading from your test kit of 50 parts per million. You know, maybe the error is plus or minus 5 parts per million, or a 10% error. You also have to multiply that error by a factor of 3, so it's plus or minus 5 times 3, or plus or minus 15. That's still a 10% error, but the absolute error is larger. Next.
I just want to point out that we've had conversations with NSF. Tom's had conversations with NSF, and they've done some analysis on this L1, L2, L3, and there are some issues with it in terms of the amount of error. Some of it's an overstated error, and there hopefully will be some work to address that, and that also dilutions do not undo any NSF certification. Is that correct, Tom? Based on your communications with NSF?
Yes.
Okay, so now that we've talked about dilution, just going back to higher levels of cyanuric acid, because we're about to embark on that with this next slide here. Like I said, and Craig brings up a really good point, with algae and different pools, different venues have different needs. And that's why we're saying that, we're not saying that any of these proposals, such as the 90 to 180 part per million cyanuric acid change request, is necessarily what every pool should be doing, but rather that this is part of a code that is for the entire aquatics venue industry. And so, different pools may, be operating with different bather loads, different chlorine demand, different sizes, different demographics, different, costs, budgetary needs that may result in their cyanuric acid getting higher, which they can address by staying under that ratio. So we're just saying that if these things are not modified, then those venues will suffer and they will hurt, because they will have to switch sanitizers, switch chemicals, and make, potentially capital investments and changes in order to do something that's more restrictive for them. So we're saying make it, at a level that's good for all. So we also talked about, minimum disinfection. We've talked about operational limits. There is another aspect of the Model Aquatic Health Code that looks at imminent health hazards. And it tries to set some criteria to say this could potentially result in an imminent health hazard. So you need to stay, within this defined criteria. And if not, because you could have an imminent health hazard, then you would either need to immediately correct and or close the aquatic venue for a given set of conditions, for any conditions that are listed in this section of the code. And so we're proposing this change request, and this is a change request that has been submitted by Rudy, Roy, Tom, and myself on our behalf. And it was recently modified. So this change request originally was different. The last time we met a month ago and we did this talk with you all, for those that were able to come, we looked at a different max ratio. So we've talked about the 1 part per million DP measured free chlorine limit as a minimum. And we still stand by that operationally and for closure, that's appropriate. And we've talked about the EPA SWIM model and how that level was 305 parts per million for cyanuric acid. So based on that, there's currently not any closure criteria right now in the current model aquatic health code for cyanuric acid. It's just not there. So it's gap. So we're saying that that should be a limit of 300 based on the EPA SWIM model. NCY toxicity for imminent health hazard. Now recognize too, again, that has a built-in safety factor of 100. Then we're saying that in addition to that, a minimum disinfection level as it pertains to efficacy should also be considered. And so we looked at several different criteria, and when we look at closure as opposed to operational targets, if we agree that the ratio concept equates to a 45-to-1 or a 50-to-1, depending on which code, as an operational target max ratio, a minimum disinfection level, then a much higher max ratio is appropriate for closure. And you're talking about something that's higher risk. And so we look basically, if you take what's current in terms of imminent health hazard standards, you'd be looking at current imminent health hazard standards are a 2 part per million DPDFC limit based on current MAC and current PHTA standard 11 with any cyanuric acid usage. And current imminent health for 300 CYA toxicity equates to a 150-to-1 ratio. We also, for the purpose of looking at a max ratio for closure, went back to, well, before we do that, let's talk about the 300. Sorry, I squeezed this in here. This is just a slide, and we're not going to go over this in detail, but this compares the EPA SWIM model and WHO's number and their calculations at a high level, and the assumptions that the WHO calculation utilized, which was not based on any substantiated data. And I'm not going to, we'll make this available to you all. We're not going to review it in detail, but the SWIM model is much more robust and is based off of data that is substantiated for the different values that are used in the calculation. Okay, so Tom, I believe you were going to talk about how Pinellas County shows us that higher risk gave us a higher ratio for closure.
Yeah, we already looked at the Pinellas County data in terms of just the cyanuric acid concentration. You can also plot the data in terms of what the ratio is, and so if you plot the bacteria concentration versus the ratio, once again, you see that even at high ratios, at up to 150 or more, you basically don't see the numbers blow up as you get to a high ratio. Again, the real risk is running out of free chlorine. And the data just doesn't show that the pools are starting to get out of control even when the ratio is up to 150. The other way we looked at this is to look at the failure rate. EPA sets up, we talked about different criteria for the different bacteria classes. So, for instance, the hydrotrophic plate count shouldn't go over 200 counts per mil. EPA's criteria in their field efficacy studies is a 15% failure rate. If 15% of your samples are over that criteria, then you have a failure. And so if you look at the Pinellas County data, we looked at the 4 different types of bacteria in the pool: the heterotrophic plate count, the total coliform count, the fecal coliform count, and the non-coliform bacteria. All 4 of those were done in that study. And if you look at the failure rate at different hypochlorous acid concentrations there, we take different ranges there. And each range has quite a number of pools in it. Values in red are where you start exceeding that 15% failure rate, which is EPA's criteria for failure. And you can see that that happens when the hypochlorous acid concentration drops below about 0.002 parts per million. That concentration corresponds to a CYA DPDFC ratio of about 165 to 1 at the upper end of the allowable pH range, pH 8.
At the closure allowable pH, not to be confused with the operational pH limit of 7.8.
You're right, at the closure. And so what this is showing is that you start seeing failure rates which indicate an imminent health potential hazard at a ratio somewhat over 150 to 1. And therefore the 150 to 1 makes reasonable sense in terms of being a criteria for immediate correction or closure, because if you stay under that 150 to 1, you have enough FAC to prevent the bacteria growth from becoming an imminent health hazard. So again, you look at the data different ways and you kind of end up at the same place. That 151 ratio makes a reasonable criteria for closure. Back to you.
All right, Roy, you're up.
Okay. Let's talk, we keep talking about crypto and people keep saying we need to be doing this for crypto and this for crypto and this for crypto. Now, this is the most ridiculous example that I could possibly come up with, but if you actually want to control crypto in a swimming pool with chlorine alone, no cyanuric acid, this is exactly the way you do it. If you look at the left-hand column, if you're running at 10 ppm maximum by Florida code, and it's probably the most people would try to run, your CT value is 15,300. If somebody's got a fecal accident at that level, that pool is going to be highly infective for an entire full day. If you're running at 5 ppm, it's going to be 2 days. If you're going to be running at 1 ppm, it's 10 days. But if you really want to kill crypto in a 75,000 gallon pool in 2 minutes, what you got to do is you got to drain 5,625 gallons of water out of the pool. And then you got to put in 5,625 gallons of 10% bleach. Now your pool is running at 7,500 ppm of free chlorine. And that will kill crypto in 2 minutes. If you are concerned about killing crypto at the same rate, this is about the only possible way you can do it. In other words, there is no practical way in hell that you're ever going to control crypto if you are using chlorine alone. And so this whole argument about draining and doing this and in that, it's complicated. We have been using hyperchlorination for 15 years. What's the net outcome? The number of cases of crypto are going up. The system isn't working. If we're going to get our hands around crypto, that means we're going to have to put secondary disinfection systems on every pool. And it's going to be UV or ozone or enhanced filtration or a combination of the two. But people that are still saying it's all a CYA issue with crypto, it is not a CYA issue. Crypto is the most chlorine resistant organism that we know of. It is a chlorine problem, not a CYA. If you want to control crypto, try something else and quit saying it's only because of this issue. It's not.
Okay, so some of you guys, we're back to diarrhea again. Some of you guys are more familiar with this protocol, it sounds like, than others. And we put this up here because this protocol is what is like Roy said, is being utilized to justify some of these risk reduction proposals. They come back to this and they say, Well, we can't have a higher ratio. We can't have higher CYA because, you know, if we have to remediate, this is what we're dealing with, and you'd have to deal with, you know, so we're going to break that down a little bit and talk about why that's an unreasonable basis to justify a risk reduction proposal or limit cyanuric acid concentrations. It's, first of all, it sounds like remediation for these AFRs is relatively infrequent in most instances. And so there's that to consider, right? You're talking about routine operation limits versus something that happens at an infrequent thing. And there's other ways to combat it, I'll just point out, and that is that parents don't let their sick kids swim in the pool. And there's multiple ways to deal with this, right? But and showering and bather hygiene, these are all aspects, and I feel like those are more effective ways. But this is the go-to way. So a couple different things. They said, you know, when you talk about looking at this remediation, you're talking about having to drain such a significant amount of water. Well, if you're already at a higher cyanuric acid concentration, you will already have to drain a significant amount of water. Okay, so the amount you would have to drain by comparison relative to what you would have to drain now is very negligible in terms of how much more water you'd have to drain. Just want to point that out, and that's going to be in the next slide. And then also, we're talking about reducing crypto, as Roy pointed out, you know, reducing those outbreaks. Cyanuric acid and chlorine is not the way to go. You need to be looking at other methods, and we're going to talk about that. And also, I also want to point out in this slide, we talk here about how this calculation does not account for the fact that once you drain the pool and refill it, you've now got a much smaller pathogen concentration. And this protocol does not account for that. So it's kill times and treatment times, and, you know, free chlorine levels are based on not accounting for that. So they would be much less once you start factoring those things in. So this is just basically showing that the amount of water that you'd have to drain by comparison is only about 8.7% more to go from 90 parts per million to 180 parts per million cyanuric acid. So it's just showing that they're harping on the amount of water you'd have to drain being so much more significant. You're talking about very, very little percentage-wise more. So that's all really this is meant to point out. Roy, did you want to do this one? Roy's going to talk about better ways to reduce Cryptosporidium outbreaks than going after chlorine and cyanuric acid.
All right, we know, and James Ambergy's done a whole bunch of stuff on this. We know that if you use a different filtration system, if you use improved filtrations, and they're all over Europe. Now, they're more expensive than what we've got in here, but improved filtration works. A deeper sand bed, and it's got to be probably 3 times deeper than the commercial ones we're buying right now. And some of those glass square filter media that we see at the trade shows, they work really well, but they're not NSF 50. And those European filters, they're not NSF 50. So now we got a code problem on there. But, you know, then James Ambergy's done a lot on, you know, polyaluminum chloride and alum. So we can flock in there and we can switch over to DE filters, but nobody likes DE filters on a commercial pool. Even cartridge filters are better. So there's other technology that we could be using. But part of the problem is some of the guidance that we're getting out of the Model Aquatic Health Code and the state codes are limiting our ability to use improved technology. So we're really handcuffed by knowing that we have these other things that are very, very effective. So we're kind of stuck until we make some headway. And that's really unfortunate.
Hey, Roy, I just had a question. I'm wondering from a cost-effective standpoint, does it make more sense for a facility if they're considering alternative ways to control crypto, to try to invest in or try to, you know, if these filters even exist, in a filter that would perform in the way that James has described, or would it be just better to get like a UV system or something like that?
Yeah, you'd end up having to do a cost benefit on those two things. The filters exist. There's a half a dozen companies that are trying to push them in the United States right now. And so it would be a trade-off. Now, the disadvantage of some of the bigger filters that James talked about is they're bigger, they're taller. And so what we did is we built our pump rooms around the currently designed filters instead of looking at better technology. Now, if we had in the old facilities, you know, some of the 50-year-old facilities where they had the old giant sand filters, you'd have plenty of room to put one of these things in. But if you got a modern facility built in the last 30 years, then a UV or an ozone might be the only way you're going to shoehorn it in without knocking a wall out.
Yeah, modern facilities, pump rooms were an afterthought.
Yeah, absolutely.
I just want to point out on this slide too that, you know, it was pointed out that I'm not saying that this happens often, but, you know, filters could be put in and somebody forgets to put it in the media. So that happens, right? The filter is not going to have any pressure. The filter's not doing anything for you. So one thing that, you know, could be done and considered, and this was discussed, is maybe there ought to be a requirement put in the code to say that you read the filter pressure and read it every day. Make sure that you're getting pressure on your filter. That will tell you if that form of water treatment in your pool is doing any work, or, you know, what frequency is reasonable. But since it's just a reading, why wouldn't this be something that you guys would do every day? Or maybe you guys already are doing it every day. But this is just, that was just something that was brought up in conversations at conferences and caucuses and things like that. So I just thought I would point that out. Okay, Roy, let's talk about your CR.
Well, I did this really radical thing and said, well, the science says the only way to control crypto is to put a UV or an ozone system on every pool. And, you know, I mean, that's what the science says. I mean, if you're going to use material that is in currently the Model Aquatic Health Code, the only things we've got are UV or ozone. And that's what the science says. And we're supposed to be limiting, you know, worrying about public health. Well, guess what? I guess that's too radical because it was voted down unanimously by the Technical Review Committee because they didn't want it. So
well, they voted a lot of things unanimously that they didn't want.
And so here is the science that says how to improve public health, and it got voted down. And if you see where my body language says I'm a little disgusted at it, this is the second time I put something in there that was based upon well-known science and was told it was too radical.
But EMAC voters can vote in favor of it. You don't have to do what the TRC says.
Now,
that is what we're getting at.
What I will say is, if you are operating a public pool rather than residential, one option you can do is on your contracts is go out there and say, I will put a UV or an ozone system in that is compliant with the Model Aquatic Health Code. This is what it would cost. And they can either accept your contract or decline your installation contract. And if they decline it and you've got a form where you informed them of the risk and they signed it, and there's an outbreak and there's 150 cases in your pool next summer, you've got a declinal where they've waived that installation. You have legal protection that you've informed them this is the best technology. And so I've been recommending that for 15 years. And I am instituting that on my commercial pools next spring. They can either accept or not, their choice, but then I've got a waiver so they can't sue me.
All right. So we've thrown a lot of information at you, but we, believe it or not, there's so much related to cyanuric acid that we haven't gotten to. We put together, we saw a different version of these tables last time, and they've been updated. And they've been updated because some CMAC members revised their change request after the conference that took place based on conference feedback and other information. And so these tables have now been updated to reflect those changes. We've already talked about a couple of them. One of them was the operational ratio got changed from a 50-to-1 to a 45-to-1 because of people being very against increasing risk relative to what it is currently, regardless of rationale behind it. The other one that we mentioned to you was the closure CR, and those two CRs that now have that has a max closure ratio now of 150-to-1, and those two change requests are now submitted, like I said, on behalf of the four of us, Roy, Rudy, Tom, and I. But there's other change requests. And so this table is very busy. And in fact, this is, there's 3 of these table slides, and this is the least busy of all of them. So I'm going to kind of try and walk you through what these tables are meant to show you a little bit. We have on the left the recommendation that we give for the vote, that we're telling you that we think the science tells us and what makes sense for this code on voting on these change requests. There's the change request number. There's a special column in between for Roy. And there is, so the change request number, and I tried to group these in a way that the change request number and the similarities are next to one another, so you can compare which ones we're telling you what we think you should vote no on versus the ones that we believe you should vote yes on. And then kind of differentiating if those CRs have been recently revised and when they were revised based on the original submissions. And this is going to be important because Tom's going to walk you guys through, for those of you who are able to stay, we're going to record this information for those to help everybody understand how to navigate the CMAQ website and vote, because this is very confusing. If this CR has been modified or revised, figuring out where to find the information you need to make an informed vote, figuring out what the TRC is saying about it, figuring out if this CR has been revised, what are you actually voting on? These things are they're not user friendly when you're trying to go in there. And so we're gonna try and help you out through that, but this table will at least tell you whether or not these CRs have undergone those revisions. It also looks at, whether or not this particular change request or proposal is something that the CYA ad hoc committee members agree upon or not. And so that will give you an idea of what do the experts think? Are they in agreement here? And if the answer is no, then there's probably some reasons for it. If the answer is yes, then we're advocating on behalf of that, because that's where the science is more solid. That's where things are more sensible. That's where more reasonable. Then there's the TRC vote recommendation. That's what they're recommending to CMAQ voters to vote, whether or not they're voting yes, no, or whether or not they abstained on it because they couldn't reach a majority within the technical review committee. The current rationale, there's just a really very, very abbreviated summary. And I want to point out that some of these CRs have rationales that transcend 15 pages alone for just the rationale. So just want to point that out. And then there's a column that talks about whether or not this CR could have known pool industry cost and operational impact. And it's based on some sort of scientific uncertainty, or it's based on scientific uncertainty. So some of these CRs claim that there's no cost, but that's not true. And some of them have cost with a justification that's based on a lot of uncertainty. And then some of them have cost that, like for secondary disinfection, not based on uncertainty. But there is cost. So that's factoring that in. And then just some additional comments and details from the 4 of us. Some CRs that we didn't review in here. One of them, I'm just going to quickly touch on them. One is the definition for agitated water. The reason why this is related to cyanuric acid is because the definition for agitated water versus flat water in pools, as it's defined in the MAC, leads to 2 different bather load limits in the MAC. And so some members are trying to apply an agitated water bather load to the risk model that's been developed, and it's not really appropriate because the model is inconsistent with the model's assumptions. And so the agitated water definition is not clear in one location, and so we're asking it to be clearer, and that would help support that. The secondary disinfection we'd already talked about. There's one on theoretical peak occupancy where it's inconsistent in the code in one area versus another, so we're saying make it consistent. One is with regards to CYA testing frequency. The CYA ad hoc group, the experts, agreed that there should be a frequency of 1 week for CYA testing for those pools that are utilizing stabilized chlorine sanitizers. So we're in agreement with that. Everyone's in agreement that that frequency be for those venues. There was a CR put in by Segura, Cal-Hypo manufacturers, to add the effect of cyanuric acid to training. However, the content that they're proposing is extremely biased and not really realistic, since it's only talking about pools that are operating with cyanuric acid levels between 1 and 10 parts per million. If you're using cyanuric acid, are you staying under 10 parts per million? How is that relevant information? So the TRC voted yes, but again, this is not realistic. And also, it says add the effect of cyanuric acid, but it doesn't even talk about the ratio concept at all. So we're voting, we recommend a no vote. Ones that we did not hit in here. So I told you that there were some revisions. In this column here where it says revised at the top, you'll see if it says yes, it'll have a yes with a date associated with that. Since we last met, there's a few CRs, such as the second one here, that were revised in November, post-conference. The second one here is one of those, and it was submitted by John Kelly, and the TRC did recommend yes. John Kelly is not a member of the CY ad hoc group. He is somewhat misinterpreting and misapplying the ratio concept and the ratio concept science, and has submitted this CR, which is extremely restrictive. And so we are recommending a no vote on that. That's one of the newer ones. We already talked about the 45:1 max operational ratio. Some of these are other ones that are pretty self-explanatory. John Kelly submitted another one that the TRC voted in favor of, that says he's basically trying to take an operational limit and basically impose it to have immediate correction requirement and or closing requirement, such that if your pool gets above 90 parts per million, that once you close it at the end of the day, you cannot reopen it until you get down to 75. And this is very restrictive, and it's not justified, and has impact, which he says there is no cost impact, but that's not true. And so we voted no, but the TRC, like I said, voted yes. Then the rest of them are pretty self-explanatory in this one, just for lowering CYA limits. Segura is putting in multiple CRs for multiple different CYA limits. Just want to point that out. Multiple ratios that they're involved in, that they're advocating for as well. Okay, and this one, we did not talk about some CRs, but we will provide some information in the supplemental slides that we'll make available to you. So one of the CRs that was submitted was to ban cyanuric acid in indoor pools. The science simply isn't there. The TRC gave an abstention on this. They couldn't reach a majority. We're saying that's not reasonable at this time. Doesn't even take into account indoor pools that might have significant amount of windows where sunlight is being introduced. So more science is really needed to be done there to say that that should be banned. And until then, it's really not justified at all. There's another change request that was submitted by my colleague, friend of mine in the industry, John Weber. Has worked with Roy a really long time. And it was to eliminate the current ban on CYA in spas. So there's really, there are spas out there that are not following this aspect of the MAC that do allow cyanuric acid in spas, and there's tons of spas and hot tubs that are outside. And cyanuric acid would help stabilize and prevent from running out of free chlorine. There's no reason why it should be banned. And there's some pretty good justification and that rebuts the reasoning that was utilized to ban it in the first place, which was based off of misconception and misinterpreting some studies and some data that's out there. So we are recommending, yes, that we eliminate that ban.
Jen, we have a question from Jerry Wallace, if I can find it here.
Yeah.
Why is cyanuric acid testing weekly not a requirement in all areas for pools?
I think right now it's a bi-weekly requirement, and we're just recommending that it be increased to weekly for those that are using stabilized chlorine sanitizer.
But I guess do we know why it's not already a weekly requirement in those areas? Or do we know? No?
It was bi-weekly before.
Okay.
And for those using stabilized chlorine sanitizers.
Okay.
And I don't know, like, I mean, you just set something somewhere and then you learn something new and you say, hey, we need to do this more often. So that's really where it came from. Roy, you're shaking your head.
Yeah, I don't know why. It's been all over the map, Jerry, on how often to test the thing. I run it every time, so I don't know.
I used to do mine weekly and that worked well.
Yeah.
But it wasn't.
It depends on if you're using, stabilized chlorine as your sanitizer or not, or if you're introducing stabilizers separately, and that's really what they're trying to get at with that weekly requirement. So the other CR that John Kelly put in, which he revised in November, was based on the WHO limit. Like we said earlier, we keep hearing about this WHO limit of 117 parts per million on cyanuric acid, even though it's based on information that's not substantiated. And they are using that to say we need to close at 117. So that the TRC voted yes or no on that one. They voted no on that one, believe it or not. And we're also
no. Yep.
Yep, they were also recommending a no.
Craig has a question that popped up for you, Jen. When voting on the CRs, will there be a brief summary like you're supplying here?
Nope.
No.
Nope.
You have to, no, there's not. This information is our way of trying to give you the most brief information you would need to know to somewhat be informed to vote on these things. If you go into any CR, you are subject to whatever that submitter included, whether their rationale was scientifically accurate or not. That is what you have. Whether or not the TRC understood it and evaluated it in a way that makes good scientific sense or not, that is what you have. So this is our scientific view on this information based on the data in the literature and based on our experience, our collective experience. And
These slides are your crib sheets and your cliff notes.
Yeah. There's some of these CRs, like I said, have rationales that transcend 15 to 20 pages, and that's just for the rationale itself. So, you know, there's lots of things to consider, and that's not even concluding like supporting documents and things of that nature. So
Jen,
we'll get to that one. Mm-hmm.
How quickly will you have these to me that I can the slides that I can present to folks following this meeting? Do you have an idea? Because I think
I can make these tables available today. The rest we've still got some supplemental slides, and I've already found some typos and stuff that we probably need to correct. I've been trying to make a note of some of them before we distribute the full slide set. But the tables themselves we could make available today.
I think that would be fantastic. Craig plopped in another comment that basically said, yeah, a couple are starting to show up now that folks would like to have these, as soon as you possibly can.
Yeah, so tables will get to you today, and slides will hopefully get to you early next week. So with regards to the other two change requests that were revised in November post-conference since we last met, one of them was Ellen Meyer Segura submitted a change request that originally proposed closure for a ratio of 45:1 for closure. And the TRC voted that down, and they said, no, it's not reasonable. Our current operational limits don't equate to an imminent health hazard and therefore should not require closure or immediate correction. And so that's what the TRC said. However, when Ellen changed that CR in November and added the 300 part per million limit based on the EPA SWIM model to her CR, they voted it yes. So we changed our CR to have, as we reviewed earlier, the 1 part per million DPDFC to 300 parts per million CYA, and now a max ratio of 150:1, which we believe is much more reasonable. It is not reasonable to say 45:1 for closure. Current operational target should be an imminent health hazard at which you require to close your venue. And so we have said 150:1, much higher, based on the criteria that we already gave you, based on the Pinellas data and other things of that nature, seems more reasonable. So those are the justifications that have been provided. I'll just say, the TRC recommendations, we disagree with many of them, So that is how we organize these tables. I think that's the last one. Okay, so now we just want to kind of just do as a quick wrap up what we've talked about today. We talked about how the Model Aquatic Health Codes was originally put in place to address Cryptosporidium outbreaks. That's sort of why they said we need to have a model code here. Like lowering cyanuric acid, trying to do with routine chlorine, that's just not the way to get there. You need improved filtration systems. We need secondary disinfection systems. That is the way to go if we want to keep people from getting sick in pools from Cryptosporidium. But this model that's been developed, it really needs significant more refinement and validation in order for us to be able to use it to reasonably accurately recommend, ratios based on risk. That's where that's at. It's not possible for this model to give us any kind of accurate estimation on risk and meaningful estimates of relative risk without that accuracy being improved. So, you know, using the model is a great tool. It's a very useful tool, but it still needs a lot more validation. Therefore, relative risk reduction proposals at this time, that they just have significant uncertainty, and there is an operational cost, known operational cost impact. So these things are premature, and they're currently just not scientifically justified at this point. But the ratio concept is solid, and that's what we should be doing, is converting those current limits to a max ratio. That's the 45:1 for an operational target with the 1 part per million minimum DPDFC, the 90 or 180 if you can properly dilute CYA maximum, and the immediate correction for closure criteria, adding the 300 parts per million of cyanuric acid in the max ratio of 150:1. So get good filtration, use secondary disinfection, make sure you have a good chlorine residual in all areas of your pool, good circulation. Check your backwash, check your filter pressure, use flocculation, post signs about bather hygiene, make sure you've got a good number of showers, and keep parents or keep people that are sick out of the pool. And here's some references. You know, I just want to emphasize once again, we really appreciate you joining us. We need your voice. It's not just with the CMAQ. We're trying to bridge the gap by meeting with you all today, because as scientists, you guys are our front line eyes on the field, and we need your input. You're the ones out there taking care of these pools day in and day out. We need your knowledge, your experience, and your expertise to be a very critical piece of this conversation. And I know that we're talking to you guys today about proposals that are already in progress, and you're probably thinking, what am I supposed to do now? All we can do now is do what we're doing and inform you and encourage you to join and vote to try to impact these results at this point. But get part of the conversation now, not just the CMAQ. Get involved, understand these pool codes, start having the conversation with these different demographics. We need pool service professionals to be part of that. And we want to improve our pools for all of us and keep our bathers healthy swimming. So thank you all for joining us. And for any of those that are able to stay later, Tom is going to review how to go about voting, and got some screenshot images to review with you guys on how to navigate the CMAQ website, which is going to be completely redone soon.
Did you want to ask for open questions at this point?
Yes.
Okay.
We want to hear from what questions you guys have for those that have the time. And then for those that are able to stay, we'll just continue recording, Rudy, so we can get in the CMAQ voting tutorial.
Okay, so anybody that's here with us, that if you do have questions, just unmute yourself. Please go ahead and ask on anything that we've covered thus far, anything that you have in mind, anything that you think we should have covered that didn't cover, but just please, no more diarrhea. All right, so open up to everybody. Once we're finished, we'll go on with Tom's breakdown.
So is there any effect that, like wipe out like monopersulfate shocks and things like that have on all of this? Because those, are oxidizers, and although they're not sanitizers, they still do their job in removing organics and things like that. So like as far as bacteria goes, like how does that, affect everything?
Roy, you're muted.
The data on monopersulfate is at pool temperatures. It has an incredibly slow rate of kill, so it's not effective as a killing agent in swimming pools. At spa temperatures, it actually has some cidal effect, and it's about half the speed of chlorine, but it is cidal in spas. But I ran a very comprehensive study on monopersulfate in 2006. And really the advantage there is, like, if you're using routine oxidation with monopersulfate, you will see less combined chlorine, and a slight reduction in your amount of chlorine that you need. So you can keep a cleaner water for chemical viewpoint, but monopersulfate should not be considered as a treatment for any germ in any venue.
Yeah, so we use it, we keep it, I cannot even think of the word, I'm exhausted. But basically we keep a residual in the pool. So we're constantly adding it in our main body of water. So that doesn't have any effect in like preventing.
You're better off on monopersulfate going to a once a week residual on that thing. There's been a number of studies. DuPont had a system 17, 18 years ago called the SAFE system, where it was added continuously, and they saw a slight increase in the number of skin rashes on continuous addition. But if you go to a weekly addition or every 3 or 4 a day addition, then you do not see that skin rash. So it's one of the very, very minor components in there, builds up on a daily basis, but it does not build up on a 3 to 5 or a once a week basis.
Okay, that's very good to know. Thank you very much.
Yeah, and the standard dose is 1 pound per 10. A bigger dose is, of course, 2 pounds per 10,000 gallons.
All right, thank you very much.
Other questions? Yay, nay? I know it's a lot of information. If you guys do think of anything after the fact or after the presentation or after you have to go that you'd like to ask that we didn't think of, get in touch with me. And if you have a specific person you would like to address that question to, I can forward that information and then liaison it back and forth to you, or at least put you in touch with the right person. So I guess at this point, one more time, any other questions?
I was just gonna say, I mean, this is not necessarily in regards to, the presentation as a whole, but you brought up skin rashes. I did have one member who complained about it, but I mean, we have hundreds of people who use our pool on a daily basis. And it was, I think one member, and then there were 2 members like a few months after that who had mentioned it within like that same week.
Yeah,
and
it's a low incidence with monopersulfate, very, very, very low incidence. But if you space your dosing out farther, those incidents will completely disappear.
Huh. Much appreciated. Now I can make everybody happy. And by that, I mean almost everybody happy because it's pools and,
Exactly.
Try my best.
Allie actually has a cold plunge over there. It's actually pretty cool. So,
which, in regards to that, I never wrote you that article because I have continued to learn more and more and more about that over the last few months.
Okay, well, we'll talk on that outside of this, but definitely still looking forward to that. All right.
Rudy, we can also provide for you to post, if you'd like, the full CRs for the 3 key ones that we're advocating for.
I think that would be helpful.
Okay.
Yes, if we can do that. What other questions do we have? I mean, I know we've slimmed down quite a bit. We've run a little long, but.
This one's for, I have one for Rudy on, do you have any more like data on this aluminum sulfate as it relates to cyanuric reduction?
Who's speaking at this point, so I know who I'm talking to?
This is Ronnie.
Hey,
this is Ronnie. Sorry.
Data is constantly coming in from the different folks that we have that are out there doing field studies. We don't have anything scientific. We did find a research document that was from 2002 from a Russian journal that supports my theories to an extent, but hopefully we'll have more on that going forward as the information tends to come in. But I'll make sure that you have everything I have.
Okay, thank you.
Does that answer the question, or did I run in a circle?
Yes.
Which part?
Yeah, no, that's it.
But yeah, we're still experiencing good results. I haven't had anybody come back to me and tell me that any of the process is reversed. So I'm still excited about it. Other questions?
Cool. Yeah, same here. Yep.
Good. Okay. Anybody else? Okay, so with that, then we're just going to have Tom. Did you want to take us the rest of the way through? I believe that's what's up next is
Sure. Sounds
your
good.
code navigation. All right, thank you.
So,
Tom, do you want to talk about the membership cost and the cycle to join for those who may not be familiar with it?
only CMAC members can vote. They run their membership on a three-year voting cycle. And so if you are not a member right now and need to join in order to vote on this cycle, I think it's $190 per person, and all of the memberships are an individual membership. For the next cycle, if you join early in the cycle, it's a reduced rate. I don't remember exactly what I think it's like $60, $120, and $190, depending on exactly when you join, but don't quote me on, maybe it's $90, $120, $190, I forget exactly, but it's, if you join early in the cycle, it's a reduced rate. There was a little bit of a mix up on this year. It looked like the memberships, if you joined a year or two ago, they ended at the end of the conference and they cleaned that up. And so people that joined a couple of years ago can get through this voting cycle. Yeah.
Right. So if you do join now, just know that your membership cost of $190 will only last you through the end of the year, but it'll be cheaper if you want to join earlier on for the next MAC cycle, which starts in 20.
You can join for the next cycle and get this vote and through the next one as well. As we've indicated, the CMAC website is a little bit clunky. They recognize that it's not particularly user friendly, and so this is a little bit of a tutorial on just how to get through their website in order to do the vote. So this is a screenshot of kind of their basic page. You sign in. It's showing up here on the top right. And that's where you sign in and out. And you can only vote if you get signed in as a member. And then your menus over on the left side there. You can look at the CRs in two different places, but when you're voting, it's probably much easier to just look at the member vote page, which is the bottom green arrow there. You go to that page, and that's where you vote and you have all the information in. And so that's what this page looks like. The CRs are listed in more or less order at the bottom there. Once you go through all the way through this and vote, then at the top of the page here, the top green arrow there, that's where you record your vote. They are convenient in that there are a lot of CRs. There's 530 CRs. You don't have to vote on them all if you don't want to. But if you want to do a good job to read through things and decide on your votes, you may want to do that at more than one sitting. And so you can record a number of votes, press the I'll be back later button, and then sign off and come back the next day or whatever and continue voting. Once you've submitted your final, once you've done recording all your votes, then you click on the Submit My Final Vote button to record your vote. Actually, if you don't do that, but you've recorded a bunch of votes, it'll take it when voting ends. But I would certainly want to submit my final vote to show that it's been submitted. Then down at the bottom, each row is a different CR. The first 5 or so are not in order, but after that, they're pretty much in order. And they're all listed there. from, well, we go to the next page. Yeah. This shows another set. And so from left to right, you have the CR number. You have the blue buttons are the TRC evaluation forms. The next column, if there are public comments, they show up there, and you can have, it says to view. If there's some public comments, you can click on that, look at the public comments. The next column is the recommended vote by the TRC, either a yes, a no, or an abstain. The section number in the MAC that refers to a very brief description of the CR, which sometimes help you figure out what they're talking about. And then the vote, and you click on the buttons, yes, no, or abstain. All the abstains are populated to start with, so if you don't want to vote on them, that's fine. It displays 10 CRs at a time, and then you page through it with the little boxes there. And so this is box 3. And so, yes, there are 530 CRs, so there's a whole lot of boxes to page through. So again, they're listed in order. You can click on the CR to view the CR itself. And you can click on the blue button to see the evaluation. You can view the comments. Really, in order to be informed on each one, you always have to look at all of those. And so it does take a little homework to go through all these and to figure out, you know, what you're voting on. And it's also important to be careful with things that are some of the CRs that are revised, because it's not always obvious what you're voting on again. So let's go to the next page.
Before we do either you or Roy know if you abstain on a particular CR, how that's counted in the voting total?
It's just not counted. Yep.
Just not counted at all.
Not
It's
counted.
not part of the 100%, 61% majority for
Right.
pathogen. Okay, thank you for that.
So next slide. There we go. And so this is on the right an example of one of the change requests, just the top and bottom. As Jen mentioned, the change requests themselves had several sections, and they can be anywhere from 2 or 3 pages to 20 pages, depending on how much people write up in their justification. And certainly some of the ones we've written are long and have a lot of description in them. So again, you click on the CR number to see the CR, and this is the one example. This is the one that the CYA group submitted to talk about distinguishing FAC from the DPDFC. Different sections. Section 4 is the actual proposed change in the code, just what wording is being added, deleted, or changed. Section 6 is a justification for that change. Section 7 talks about the estimated cost, and I think they are being more stringent about people writing up what the cost is or is not this year compared to the last round, since that was an issue. And then section 8 is some of the supporting information and references and stuff. At the bottom, there are 2 or 3 boxes. If you want to go back to the voting page, you have to go down to the bottom and click on the box that says close. If you just hit the back page button on your browser, you'll get back out of the CMAQ website. and so just don't back up with your browser button. You have to go down to the bottom of the CR and hit close. You'll see there is a print button there. If you actually want to print them out, you can hit print, and then you can save a PDF version of that CR. Some of the CRs also have supporting documents, and if they do, you see the download supporting documents box, and you can click on that and then download those files as well. And hopefully, you know, if you read the CR, it'll point to, you know, supporting information that was filed as well. I will point out the software for these, you know, putting this in, it's a little clunky in that if you have figures and tables in your CR, they don't translate very well. This isn't another word processor, Microsoft processor. And so figures and tables don't translate very well into their software. And so people that have figures and tables will often put them in the supporting documents for you to look at. And we've done that on ours. If you click on the blue button for the, you get the TRC evaluation form, and this is a little bit of what those look like, top and bottom again. This is the evaluation form for the same CR. Again, it gives the proposed change. It gives the recommended vote, which is kind of in the middle there. I don't know if you can put a cursor there, Jen, on there on the, yeah, that line right there, TRC recommendation. There's some buttons there, and it's punched yes vote over there, which, pet peeve of mine, you can almost see that dot there that says it's a yes. If a CR has been revised, there's another section further down that will show the revision. And so you have to dig down into the evaluation form to see what the revised CR says, because many of the CRs that are posted, they're posted as the original version, and you can only see if it's been revised by going down into the evaluation form.
That depends, Tom, on when they were revised, if they
Yes.
were, what point in the CMAC process that they were revised. Some of the ones that were revised after the CMAC conference, those revisions are reflected in the CR itself.
Yes.
And then the TRC might have done some minor wording corrections as well to those CRs. But like Tom said, some of those revisions are only found within the TRC evaluation form. And just a minute ago, Tom mentioned the blue dot. This is the blue dot that he's talking about to find that TRC evaluation form, is this TRC column. That's the blue dot.
Yes. The evaluation form also summarizes their discussion and their decision, you know, kind of what things they considered when they made their decision. It's fairly brief. The different TR champions write each of these evaluation forms. Each CR is assigned to a champion, and they write up the evaluation form. Some of them do a better job than others in terms of writing up the discussion and the decision. They're supposed to summarize kind of the pros and cons of the CR, particularly if there was discussion of that in their discussion. There again, you have to go down to the bottom of the page to close it, to go back. And you can also hit the print button and print out this TRC report again. So yeah, then you hit close and you go back and go down to your next one. Obviously, if you really want to do a great job, going through all 530 CRs is going to take some time. The TRC spent hours and hours and hours discussing all of the CRs. Most of you probably won't really be concerned with a lot of those CRs. A lot of them are construction and, you know, CRs, and maybe you're, as an operator, probably not that worried about some of those. But it can take a little while to go through them all. Okay, is there another? That's it on that one. Okay, any questions there? Hopefully that'll give you a little bit of a guide in terms of making your way through the website. Again, it's not particularly user friendly, so it's easy to get kind of lost.
Sounds like university websites.
Like Jen mentioned, I mean, they recognize that it's a little clunky and tough to navigate, and they promised after this voting cycle they're going to put out another major overhaul on the website. Hopefully, the next one will be a little easier to use in the future.
You guys have any questions about that? It's very complicated to utilize the website, but do you have any more questions about that or any of the content?
Anyone?
I'm good.
Thank you for sticking it out with us.
I mean,
Yeah, troopers.
Those
I'm
are
the
the
hard-headed one in the company, so, you know.
what company, Allie?
Do what?
You said you're with what?
I said I'm the hard-headed one in the company. So,
Vouch
you know,
for her.
if I can make it through Gainesville Health and Fitness, I can make it through anything.
Thank you. We really
Okay.
we honestly have a lot of questions for a lot of the people that have attended today, and we didn't get a chance to get to a lot of those questions we have for you all. And I hope that we can do that more at the next session.
Yeah, that would be nice. I definitely, because a lot of this had to do with cyanuric acid and, you know, cyanuric acid versus chlorine ratios and things like that, you know. But there were certain bits and pieces, like I jotted down notes because